short moment. And then we'll get started. All right, okay, we'll kick it off since we'll start our meeting with some housekeeping. My name's Kirsten Isaacson, pronoun she, her, filling in for Chair Oscar Arana today. He will be joining us later, but had some conflicts, so won't make the whole meeting today. Dr. Santos, something really funky is going on with your picture for me. Hopefully you're hearing okay.
I'm hearing okay. I had to do an update to get in, so that's interesting. That I don't see it flickering on. I mean, I do see the small thing flickering. Not quite sure what to do about that.
Yeah, why don't you try turning off your video for a couple minutes to see if it's just your internet waking up this morning.
Wake up! Wake up!
Well, good news is you can hear and we can hear you, so we have the most important part.
Maybe I'll bring the Alexa gadget in here and yell at her. She could wake up. Okay.
All right. The Zoom chat feature in today's meeting only allows meeting attendees to message the host and co-host and no other meeting participants. Any questions, thoughts, comments can be sent via Zoom chat to the meeting host co-host, and you'll see that Tara's great about passing things along. And all materials for today's meeting are available on the Oregon Health Policy Board website and are hyperlinked in today's agenda. Tara, I hand it to you to see that we're all here.
Okay, great. Thanks, Kirsten. I'll go in alphabetical order. So we know Oscar Arana is going to join us a little bit later in the meeting. I wanted to do a roll call for Ebony Clark. All right. Do we have Jessica Gomez? Right. Kirsten Isaacson?
Present.
Brenda Johnson?
Here.
Melina Moran?
Present.
Bill Kramer?
Here.
Sandy Sampson? John Santa?
I'm here.
Okay, great. We have 5 members present, so that's quorum. I will check with the others. They're probably just in the process of joining. Thank you.
Tara. Right, so first up, updates and announcements. I did want to highlight that February is Black History Month. It's a wonderful occasion to celebrate and be inspired by the legacy of Black Americans in our country. And glad that we acknowledge that in our state. The committees of the Oregon Health Policy Board quarterly progress reports are included in today's meeting materials packet as attachment number 1.1, committee digest for 2022 Q4. I know there was some kind of mixing with our agenda as we made some last minute changes, so I'm going to try to highlight those numbers so we can all make sure we're looking at the same thing, but it's just changes of orders, not content. And attachment 1.2 in today's agenda and meeting materials packet is an update from OHA's Healthcare Market Oversight Program. HCMO provides regular updates to the Health Policy Board to keep us connected to mergers and transaction applications for review process in Oregon. Thanks for putting those links in the chat, Tara. So quick review of what we will be talking about in today's agenda. Topics we'll cover. We'll have agency updates from Director James Schroeder. Healthcare provider incentives program evaluation will be presented for board's vote of approval. And this update will also include follow-up questions from last month's meeting regarding program expenses. OHA's government relations team will join us for our very first 2023 legislative session update. And we'll have dedicated time for public comments, which I believe there are some, which we look forward to. And in the second half of our meeting, we'll receive an overview of the governor's proposed 2023-25 budget. And we'll end with a important and lengthy, if we need it, discussion about 2025 CCO 2025 or 3.0 or whatever you want to call it, but the agenda calls it CCO 2025. But our first item of business will be to vote on the draft January 2023 OHPB meeting minutes. Draft minutes are listed as attachment number 1 in today's meeting agenda and posted to our website for public viewing. Is there a motion to approve the draft January 2023 OHPB meeting minutes?
This is Brenda, so moved.
Thank you.
Second, this is Bill.
Great. All those in favor of approving the January 2023 minutes?
Aye.
Any opposed? Abstentions? Thank you. Great. Okay, well, with that, excited to turn it over to OHA Interim Director James Schroeder. Now that you've had, I feel like last month we caught you on day 1 minute 21 or something like that. So welcome aboard.
Great, thank you. So yeah, for the record, James Schroeder, he, him pronouns, interim director at the Oregon Health Authority. Yes, excited to be engaging with all of you a month in as opposed to a few minutes in. So I'll start with just a few reflections on the last almost month, and then try to give you some updates on, some really big and important things that we're working on and facing as a state. So, I think the first thing is just to acknowledge and recognize, like, we're in a state of transition, right? So, new governor, new governor's team, I'm new, there's just a lot of transition. And at the same time, we have so many big things that we need to make sure that we do well, to, really protect and not harm, right, all of the gains and individuals that we've provided coverage for and will provide into the future. So, it's been a pretty great but rough experience in the first month. I feel super supported by both the governor and her team, and of course the leadership team and folks at OHA. So that's not the rough part. It's just a lot, right, in a pretty short amount of time. And I think it's the first time I started in a new role where it's like everything's full. Like, there really isn't a lot of time to get caught up. You just kind of have to dive in. But it's been really good. And, the external support from community, healthcare, et cetera, has also been fantastic. And so just want to, acknowledge that as well. So now I'll try to dive into some of the updates, and you'll find with me, like, I'll probably loosely follow what the agenda is in there, but maybe a little bit. So the first part is the, redeterminations and the ending of the public health emergency. So I think all of you are tracking that those two things are now separate and distinct from each other. So redeterminations are no longer linked to the end of the public health emergency. So redeterminations for us will start on April 1st. The end of the public health emergency is 11 May. Sorry, that's military, May 11th. And it has a lot of things that I'm not going to talk about today. I think part of my message here is I think we are over focused on redeterminations, which is a big important thing. But there are a lot of other impacts that are going to come potentially from the ending of the public health emergency that we should be talking about and tracking a little more. So I'm just going to acknowledge I'm not going to do that today, but set that up for future conversations and updates. So today I'll primarily focus on redeterminations. So a lot of, good news around redeterminations, right? One, it's a big lift, right? We all know that. We're going to have to redetermine 1.4 million individuals, many of whom have never done this before or have learned over the last couple of years that not responding had no consequence. And we're going to really need to make sure that, we do everything that we can to not lose anyone in this process. The good news is that we have new tools that we haven't had in the past, right? So people now have 90 days to respond once the request hits their mailbox or whatever means they've been contacted. Historically, it's always been 30. So 90 days is a nice change. We can utilize clinical patient information, not the clinical side, but the addresses and contact information, which we've never been allowed to do before. So that we already have a process of reaching out, if we get return mail, reaching out to the CCOs, et cetera, to try to see if they have a more current, list of contact information. So that's an incredible new tool that we didn't have before. And 3, CMS has published some loosening of historic rules about how others can help and participate in this process. So historically, it's been pretty locked down that the state can do most of it. There's a few things but they really loosen those up. So my message around this is, OHA and ODHS and others have worked really hard to be prepared for this. Is it going to go perfectly? No. Do we still need some extra capacity and bandwidth? Yes. So what we are working on is we already have a contract in place to add more call center capacity and volume. We are working on a plan of what would it look like if we include CCOs and potentially others in that broadening of call center capacity. Many of our members call there first when they get the notice in the mail or however they were notified. So we should think about, setting it up that the CCOs have all the tools that they need to help individuals so that they may not even need a referral to the state call center, right? If we can take care of it there in one touch. So we're working really hard to figure out how do we be more creative in this space and broaden what is really needs to be a statewide effort around this. So how do we engage others in this in a way that perhaps we haven't done in the past? So, my other ask for all of you and, providers, et cetera, is to make sure that we're talking to OHP members about, one, the importance of us having current contact information. That's super critical. And the second is we really need you to respond, right? So like I said, for 3 years, if you didn't respond, nothing happened. And now we're keeping the same process of sending out the notification, but now there's a potential consequence if you don't. And so that's a shift. And we want to make sure that individuals are tracking that. And that this has to be a collaborative statewide effort. Because if we don't do this well, all the other things that I'm going to talk about are going to be not very easy to do. So I'll stop there on the, redetermination part, but it is definitely top of mind. I mean, it starts in less than 60 days and there's just a lot riding on it. So last thing I'll highlight is what I started with is all these other things that are tied to the PHE, like additional dollars, right, under the SNAP program that have been going on for the last, almost 3 years. Those will now go away, right? There's also childcare benefits, other things that we need to be thinking about as this policy board. but also just a, community at large around what are we doing for those other things, and we are. So, some will be able to, and others, will probably fall off. And so we'll need to be thinking about those, a little bit more broadly and directly than I think we have. So the next piece that I'll update all of you on is the 1115 waiver. So lots going on in this space. So kind of in order of what we're going to see first. So EPSDT and some of those are already, like, those are going to happen. We don't focus a lot on those, but those are important. So EPSDT is the early periodic screening for developmental testing, right? So what it does is, if kids are being screened and found to have developmental delays, this then opens up a Medicaid benefit set for them to then receive the services that they need. What happened in the waivers, it broadened who's eligible for that. So that's an important piece. We don't talk about it a lot, but wanted to highlight that. The next one that'll happen is continuous eligibility or enrollment. So kids under age 6, once they redetermine, they will be continued without having to reapply or redetermine until they hit age 6. That's a huge shift. And so crucial to not, having continuity of care for these kids. For 6 and older, it's 2 years. So that continuous eligibility starts on 7/1/23. Now, don't worry, those that are redetermined April, May, and June will not lose out. So the CMS is allowing us to roll those in so that they'll also, have that continuous eligibility. So that's an important thing to know. We just got word yesterday from CMS that, and I think I shared this with all of you the last time, but there is a little cost to the continuous eligibility that CMS is, giving or imposing on Oregon. So it's a 2.6% decrease in the federal match for all ACA members. Originally, CMS was thinking that this would start on 7/1 for all ACA members, which would have come with a pretty big cost. They have now agreed that they will only apply that decrease once an ACA member is redetermined. So that's a huge shift in the cost of this. And we just found that out yesterday. So that's really important. The next piece that will come into play are the HRSN benefits. So really the social determinant benefits, housing, nutrition, and climate support. So those will start on 1/1/24. I think the important thing for all of us to know and understand is we're not going to be able to start all of those at the same time. Out of prudence and making sure that we do this well, we're going to need to have a phased approach in 24. Start with housing, start with some of the transitions populations that we've highlighted before, and slowly roll into these benefits so that we make sure that we do it in the right way. So that's just an important expectation setting that we have the authority, but these are big lifts, and we want to make sure, just using housing as an example, that Medicaid is not off on an island working on housing that is not connected to what's happening in the community with housing providers, counties, safety net clinics, et cetera. And that's why we want to make sure that we take our time and do this in the right way so that it is truly a coordinated, collaborative effort on all of these, and not something that we just kind of drop in and then hope that all those things are coordinated and collaborated in a thoughtful manner. So you'll also hear from that is the approach, right? So I say this over and over again, the housing benefit within OHP is not a housing program. It is a housing benefit and a way to pay for supportive housing services. And because it is a payment source and a benefit, it needs to be incorporated into the current continuums of care for housing, not as a standalone program, because it's not. And want to make sure that people understand that it's really complementary to what's going on, not a standalone thing by itself, because it's just not enough, right? We don't want to do that and be an island unto ourselves. The last piece related to that, it's not in the waiver, but is the bridge. Now we're calling the temporary expansion to Medicaid eligibility. So that is for individuals that are over income, so over 138 up to 200% of the federal poverty level, making sure that we have that set up to catch people or transition people if they're over income from Medicaid, so that they don't lose coverage while they are either going to a marketplace plan or to the potential basic health program that we might establish in the state. So we should have CMS approval for that in the very near future. So my hope is in March when we meet, I'll be able to share that we have that approval. But we have the operation set up so that, you know, that can happen. And it's an important part of this maintaining coverage continuum that we're talking about. So with all of those things going on, not to be in conflict with what you'll hear a little bit later about the procurement, for 2025, is to just highlight that we're, stepping back for a minute and really looking at, is it actually smart and prudent to layer on a reprocurement for the CCOs at the same time that we are trying to do redetermination and implement these new waiver benefits. So the governor, her office, my team, we are talking about, what are other options, and is that the right thing for us to be doing? So I'm not messaging a decision. I'm messaging that we need to think about that because there is so much, and is it the right and prudent thing for us to be doing at this time? And, could we think about an extension for a while so that we can do that in a thoughtful way and not put other things at risk that are so important to our populations? So wanted to share that as a little bit of forecasting, and we can talk more about that in March because we'll know more then. So behavioral health, I'm not going to actually spend a lot of time on today. There's lots that we could talk about, and obviously lots of need and focus there. I will share that we are taking an approach of really looking at the entire behavioral health continuum, and how do we, as communities, et cetera, right, like really look at that continuum of care where we have gaps, and really try to look at that as a whole continuum and strategy. Included in that, of course, is the state hospital. And so I want to make sure that, that is brought up, that it is a big part of the discussion of, what, it plays a big role, right? And, we have to be working on that with community, et cetera. And so we're really working on setting up those conversations. Excited for Ebony to start on the 27th of this month. She is taking some well-earned time off between the county and here. And I'm really trying to honor that and not bother her very much during this time off, but very excited about her joining on the 27th. So connected to that, an announcement on a new individual joining the governor's team, if you haven't heard already. So Rachel Kearns Henry is joining the governor's office. Oh, there you are, Rachel. And I'm going to get your title wrong, but she's basically working with Health and Human Services, and is my, one of my key partners, because I have others right in the behavioral health space with Annalise Stolf, on the governor's team. So very excited. She's like in week 2 or 2.5, something like that. So excited to be working with her, and wanted to make sure that all of you were tracking and aware of that. And I already mentioned Ebony. I'm not going to hit a lot on the legislative session. I know our GR folks are going to spend a bit of time with all of you and deep dive that a little bit. So I won't highlight much there. I also won't spend a lot of time on the governor's recommended budget, as Dave Baden is going to do that. I will share that hopefully you saw the clear connection that the governor had with her priorities and what she put out in the budget. And so much of that is connected to the work that I just highlighted, right, that we're working on across agencies, not just OHA, around the Medicaid waiver, et cetera, behavioral health, housing. It's all interconnected. And not by chance. So Dave will dig into that a lot more with all of you. And so I will pause. I've been talking nonstop for like 20 minutes and see what questions or comments I have from the policy board. So I don't know if I'm supposed to call on the hands up or if someone else is, but I see a hand up. John Santa.
Thanks for that summary, really helpful. I'd just like to mention children. Governor Brown was very explicit about her commitment to children. And I have a feeling that Governor Kotek is as dedicated to children, though she doesn't mention them as a priority. And you mentioned ESPDT, you mentioned the continuous eligibility. So that's clearly there. OHPB has done a lot of things related to children. I think we're proud of the kindergarten readiness work and that metric. And I'd just like to urge that, it might be good to be more explicit about, in this tricky time, the ongoing and significant commitment to children.
Thank you. Appreciate that. And you're right. It's not because it's not a priority or not happening. So I'll make sure and do a better job of highlighting some of those things. I will share that within the behavioral health space, it is a huge priority and area of focus and discussion. And, frankly, one of my concerns. And so, there it is. There's also other parts to the work that we're working on besides the continuous eligibility and EPSDT that's in the waiver. So children with special healthcare needs now have, the ability to stay enrolled in Medicaid through 26 in a continuous way. So, I know those are somewhat tactical, but there is a lot of focus and discussion. And so thank you for highlighting that as something that we just need to highlight more. Others, questions or comments? Brenda.
Thanks for that report. I agree with Dr. Santa, really helpful information. My question is for you, James, and it may be premature. Happy if you want to, bring back a response some other time. It's about the linkages within the infrastructure itself and the role that you see that OHPB and our Behavioral Health Committee in particular may play as we align with the governor's priorities, and how you're thinking about linkages. It's more of a, yeah.
Yeah, so, you're right. Like, I don't have the answer to that, but I will share. Hopefully you'll hear from me that is what I think about, right? So, just like redetermination, how do we link all of the places that, one can have a role, should have a role, are touching the individuals already? The same is true here, right? With behavioral health, the Medicaid Advisory Committee, the policy board. Frankly, and this isn't an excuse, but it's just reality. Like, I'm adjusting to oh, we have that, right? So part of it for me is really understanding what is the landscape and how do we, figure out how to, really link all those things together and join in so that we're not just reporting out, right? But it's also, soliciting input and, the value that each of those different groups bring, right? Because we've set up, ones that are members, focused. We have some with a lot of people with lived experience. We have others that are more from the system side. And so how do we bring in all those perspectives? So that's more of a philosophy answer to your question, Brenda, than a direct one. But it is one that is top of mind for me. And I know it is for the governor as well. All right, others.
Okay, well, thank you. If I'm missing any hands, speak up now. Don't want to cut you off, but without that, thank you so much, Director Schroeder. Really appreciate. And welcome aboard. Glad you're getting your feet under you. Lucky to have you. And I also want to say good morning to Jessica Gomez and Sandy Sampson. Great to have both of you here today. Okay, so next up on our agenda, I want to welcome Neelam Gupta, OHA Director of Clinical Supports, Integration and Workforce Unit, and Mark Overbeck, Primary Care Office Policy Lead. They're joining us today to present for OHPB's vote of approval, their evaluation of the effectiveness of healthcare provider incentive programs in Oregon. We'll also hear additional information on the program's administrative costs that were requested in the January meeting. And just as a reminder, that it was in that meeting that we voted to approve the HCPIP allocation request. The evaluation is attachment number 3 in today's meeting agenda, also posted on the OHPB website. And supporting slides are included as attachment 3.1. So welcome, Neelam and Mark. Please begin when you're ready.
Hi, good morning. So wonderful to be here. I'm joined by a few other members of our team, Leah Festa and Jill Boyd, who work directly with the Healthcare Provider Incentive Program. And I assume that our slides are being pulled up. Great. Terrific. And we're so pleased to come here and talk to you this morning about the evaluation report. I just first of all want to acknowledge that this report really reflects the contributions of a lot of staff here at OHA. So just want to acknowledge all of them. Next slide, please. We're going to start by giving you a background on the healthcare provider incentive programs in Oregon and the evaluation itself. Then also talk a little bit about the impact on the healthcare workforce, the data collection that we were able to do and some of the constraints, provide a broad overview of the funding for these financial incentive programs, and then talk about expansion efforts since the last evaluation. Then we're going to go into more detail about each of the incentive programs, and then wrap up with lessons learned and considerations going forward before taking your questions and comments. Next slide, please. So first of all, starting with giving you a background on healthcare provider incentive programs in Oregon. Next slide. So this report reflects the passage of House Bill 3261 in 2017 that required the Oregon Health Policy Board through OHA and its partners to create the Healthcare Provider Incentive Fund within OHA. And this fund really took multiple provider incentives, which were disparate, and consolidated them into a single pool. known as the Healthcare Provider Incentive Fund. This fund is administered in collaboration with the Oregon Office of Rural Health at OHSU. You might recall last month we came to you with our healthcare needs assessment, which is also required by House Bill 3261. That report is done every 2 years, and the part of the purpose of the report is to provide proposals to address the identified needs with the fund programs. And then lastly, why we're here for you today, in front of you here today, is to present about this third bullet. The legislation also requires OHA to evaluate the effectiveness of state-funded financial incentive programs every 2 years in recruiting and retaining healthcare providers to practice in rural and medically underserved areas of Oregon that serve Oregon Health Plan members and Medicare patients. Next slide, please. And then some additional background on the evaluation itself. This report is the third evaluation on the effectiveness of incentives since the legislation was passed. The report summarizes data from the fund's inception in January of 2018 through June 30th of 2022. The report also includes data on 3 fund initiatives. The first is the Healthcare Provider Incentive Program, which includes several incentives: loan forgiveness, loan repayment, scholarships for OHSU students, as well as for non-OHSU students, and rural medical malpractice insurance subsidies. Another initiative is the Healthy Oregon Workforce Training Opportunity Grant Program, also known as HOW-TO. Both of these were initiated by House Bill 3261. And then a third fund initiative is the Behavioral Health Workforce Initiative, which was created by House Bill 2949, passed in 2021, and then modified by House Bill 4071 in the last legislative session. And it also includes data on 2 incentives separate from the fund. The Rural Medical Practitioner Tax Credit Program, and then the very large investment in behavioral health workforce stability grants from House Bill 4004, which was passed in last year's short session. You might notice that some of the incentives have asterisks by them, and those indicate incentives that are included in this evaluation for the first time. So for the first time, we include the scholarship data on the scholarships for OHSU students, the HOW-TO grant program, the Behavioral Health Workforce Initiative, and the Behavioral Health Workforce Stability Grants. Next slide, please. So this slide really shows the positive impact that provider incentives have made on the healthcare workforce. In total, among all these various incentives, at least 3,585 individuals who are students and practicing professionals have benefited and been able to either enter education or enter or remain in the workforce as a result of these investments. And this count represents an unduplicated number of recipients of these incentives. There are some footnotes at the bottom which remove some recipients. For example, primary care loan forgiveness recipients then can go on to receive loan repayment. So there's some additional information on the bottom there. Next slide, please. And then provider incentives have also had an impact on increasing workforce diversity and access to care. For incentive recipients for whom race and ethnicity data was collected, 34% of students and practicing professionals identify as people of color or tribal members. And then we also did an estimate of certain incentives and the impact on direct patient care. And so students and practicing professionals receiving loan forgiveness, loan repayment, and scholarship incentives through the Healthcare Provider Incentive Program are estimated to provide over 1 million hours of primary care and dental care to about 440,000 patients. Next slide, please. And then data collection, in particular on race, ethnicity, and or language, started with some incentives during this reporting period. We have collected this data for loan repayment since the beginning of the program and phased it in for other incentives, but not all incentives. And OHA is working with our internal data experts and the Office of Rural Health to begin collecting data compliant with race, ethnicity, language, and disability standards in 2023, also known as REAL-D standards. And then I just want to note that we did have some instances of small numbers, and you will see that throughout the report, there is suppression of these small numbers to retain confidentiality of the identities of students and practicing professionals. So I just wanted to note that as well. Next slide, please. So this is an overview of the provider incentive program funding. The healthcare provider incentive program, you know, it started partway during the 2017-2019 biennium with $14 million allocated. And you might recall at the last meeting, the approval of the additional allocation. This number reflects what was allocated as of June 30th, 2022. The Healthy Oregon Workforce Training Opportunity Grant Program, or HOW-TO, had 34 awarded projects totaling just over $23 million. The Behavioral Health Workforce Initiative had just over $80 million allocated, and you'll hear more information about the awards and loan repayment and in clinical supervision grants as we go through each of the incentives. And then the, you know, again, very large investment in behavioral health workforce stability grants. And I just wanted to point out that the Healthcare Provider Incentive Program, that funding, unspent funding from one biennium is carried over to the next biennium. And then lastly, that the Rural Medical Practitioner Tax Credit Program, since it operates as a tax credit, it's not allocated funding, so that's why you don't see it here in this list. Next slide, please. So since the previous evaluation 2 years ago, OHA has made major changes in the incentive programs over which we have control over, really to increase equity and address pandemic challenges. Some of these major changes include we provided flexibility for awardees to practice via telehealth given the pandemic. There was also, as you saw in the previous slide, additional funding for behavioral health workforce. You might recall about 2 years ago, we did come to request an allocation through the Healthcare Provider Incentive Program to expand a loan repayment to certain types of behavioral health professionals, as well as then the more recent additional legislative investments. We, again, expanded the collection of race and ethnicity data to other incentives. And then we also increased our focus on equity by convening provider work groups from communities experiencing equities and making changes to some of our programs. And then lastly, we'll talk a little bit more about this in subsequent slides about really just starting to develop an anti-racism approach to support providers of color. We started to examine information on experiences that they encountered with racism, implicit bias, and microaggressions. Next slide, please. I'm going to turn it over to Leah Festa, who's going to walk us through the Healthcare Provider Incentive Program incentives.
All right. Hello, everyone. Good morning. I'm Leah Festa, she, her pronouns, and I am the Healthcare Provider Incentives Program Coordinator. And yeah, I'll take us through several of the incentive programs. If we could go to the next slide. So we'll start with primary care loan forgiveness. This one provides students enrolled in participating primary care education, as well as in a rural training track, forgivable loans for their tuition and fees. And that's in exchange for a service obligation at an approved practice site. So this incentive has awarded approximately $2.6 million and 5 annual award cycles to 51 future clinicians. And in terms of data we collected for this incentive, we did begin using a modified Real D form in 2021 to collect race ethnicity information. So you can see here, we reported less than 36% of recipients identified as students of color or from tribal communities. And then in the bar chart on the right side, you can see the number of students seeking loan forgiveness has exceeded the available award funding. We estimate approximately 75% of applicants are awarded. And then the next slide, we have a table. This summarizes incentive recipients by school and program of study. Most students were enrolled in primary care disciplines, and we did have a small proportion in oral health as well. So give you a moment, take a peek at that, and we'll move on to the next slide. All right, the next incentive, this one awards recipients by repaying student loan debt in exchange for a service commitment at a qualifying site. So there have been 17 quarterly cycles awarding $16.7 million to 295 practicing clinicians across the state. And of these recipients, 34% identify as people of color or from tribal communities, and 34% reported speaking a second language. In July of 2021, the Healthcare Provider Incentive Program expanded loan repayment to behavioral health professionals and awarded over 3 cycles to behavioral health. However, as Mila mentioned earlier, with the passage of House Bill 2949, OHA transitioned the behavioral health awards to our lovely colleagues, the Behavioral Health Workforce Initiative in April 2022. So that's just a side note. As you can see, the bar chart is kind of small, but the top right corner shows that the number of practicing professionals seeking loan repayment has increased and has consistently exceeded the available award funding. Over time, we estimate approximately 32% of applicants have been awarded for this one. And as healthcare professionals continue to seek relief from their debt burden, we do expect this trend to continue. And then the table on the bottom right gives you some more information on a breakdown of our recipients by race and ethnicity. And on the next slide, we have a really big table. This incentive has obligated more than 16.7 million. As you can see, a total of 295 practicing clinicians. And here we're providing a summary of the recipients by their discipline and the award, the average award amount. And so we have approximately 39% of recipients in primary care, 40% in behavioral health, and 20% in oral health. There's a lot to process on this slide, so we do have these materials for you to take a peek at afterwards as well. So we will move on to the map. So this map is actually organized by the Oregon Health Policy Board identified regions of the state, and it shows our distribution of incentive recipients across the state. We have professionals in 33 of the 36 counties who have received awards. And this just kind of shows you, the breakdown across the state and where our providers have been working. And next slide. So our OHA Healthcare Reporting Workforce Program provided a qualitative analysis of a survey that our partners at the Office of Rural Health conducted in July 2022 on our loan repayment recipients' experiences with this incentive. And so the survey results revealed some key themes. First of all, most respondents expressed overall satisfaction with the loan repayment. Some of the feedback we heard was it resulted in a lightened financial and mental burden, allowing them to live and work comfortably in an underserved community. Other respondents noted room for improvement in the administration of loan repayment. And so they specified encountering difficulties with invoicing and delays for payments. As a result, we have both at OHA and with our colleagues at the Office of Rural Health hired more staff to address our increase in contracts. Respondents also had different perspectives in describing their future career prospects in the field. And finally, respondents commented on experiences with racism, implicit bias, and or microaggressions individually, with patients, or within the practice. So here you can see a couple of the statements we pulled from the survey. And we will go on to the next slide and move right into the Healthcare Provider Incentives Program includes 2 scholarship incentives. First, we have the Scholars for a Healthy Oregon Initiative. Sometimes we refer to as SHOE, so if you hear me say SHOE. This provides full tuition at OHSU for 4 clinical programs. In exchange, recipients agree to service commitment at a qualifying site. This incentive is funded to OHSU, and they administer this one. And so there have been 3 annual award cycles since funds began running through our program. Of the 55 students receiving scholarships, 51% have identified as people of color or from tribal communities. And overall, 30 students have entered into their service obligation. So the table on this slide summarizes our awardees by discipline. And then the next slide, we have the other scholarship program, which is modeled after SHOE, to provide equitable scholarship opportunities for students at non-OHSU educational institutions. And this one is relatively new. Since 2019, there has been 1 award cycle of 1.35 million to 16 students. Less than 5 students have entered into their service obligation. Most of them are still completing their training programs. And this table also summarizes the number of students receiving awards by school and discipline, in case you're interested. And I'm going to pass off to my colleague Jill to talk about some of our other programs and incentives.
Thanks, Leah. Hi, everyone. I'm Jill Boyd. I'm the Healthcare Provider Incentives and Project Coordinator, and I work with Leah and Neelam on the Healthcare Provider Incentive Program. And I think we'll move to the next slide to talk a little bit about the Rural Medical Insurance Subsidy. This was launched under House Bill 3630 in 2003. So it's probably one of our longer programs that we've had, and it has provided malpractice premium subsidy payments for qualifying doctors and nurse practitioners practicing in rural areas to provide essential services such as obstetric care. Currently, we're working with 9 insurance carriers, and since the last evaluation, we have added one more carrier. So we had 8 prior, and now we have 9. And there has been a decreased utilization of this incentive, which may be due to the healthcare systems paying for clinical premiums, being part of larger systems, larger IPAs, things like that. The qualifying providers must serve in a location that meets the OHA's definition of a rural practice. And the subsidy payments for the Oregon Health Authority are a percentage of the provider's malpractice premiums, which is dependent on discipline. There's 80% for physicians and there's nurse practitioners in obstetrics, 60% for physicians in family or general providers providing obstetric care, 40% physicians and nurse practitioners practicing at least one specialty, and then 15% for all other physicians and nurse practitioners. And the small little table to the right shows kind of the subsidy enrollment since 2018 through 2021. And you've seen it's kind of ebbed and flowed. I think during the pandemic, we went down a little bit and then we're kind of bouncing back up in 2021. Next slide. So this slide is just really talking about kind of the erosion in progress and increasing primary care FTE in our priority areas. So we're using the Healthcare Workforce Reporting Program data. We've identified 16 quote unquote priority areas that have had seen no primary care provider or dental care, or we've seen an acute shortage since the last reporting period. So some of the possible reasons for the primary care capacity decrease is maybe a lack of healthcare system infrastructure. Of course, COVID-19 pandemic has had significant impacts in our workforce. And one of the areas that we do want to look into more data to determine whether these reductions are related to pandemic or we're seeing some long-term system instability. So some other observations, we have seen a larger number of people leaving the incentive programs due to various personal and professional reasons. But this really small table to the right also kind of shows these 16 priority areas. And we have seen since the last report that 6 areas have had an increased FTE. There have been 3 areas that have reported no provider FTE changes, and then 7 areas have experienced a little bit of a decline. So it's really difficult to see, but again, as Leah mentioned, we do have these provided for you so you can take a look at those a little bit longer. I'll move on to the next slide. So I'm also going to talk a little bit about the Healthy Oregon Workforce Training Opportunity Grant Program. And fortunately, we also have our newest colleague, Melissa Yates, who is the How To Grant Program Coordinator. So next iteration, I may not be the one presenting this information, it may be Melissa, but since this is her second day, I'll be going ahead and presenting this information as well. So next slide. So a little bit of background on How To. This was established in 2018 by House Bill 3261. And this again has been an OHA, OHSU kind of partnership collaboration, and of course, under the policy direction of the policy board. Thus far, we have awarded 34 projects in 4 rounds, totaling a little over $23 million. And we have had kind of a maximum award amount of $1 million over the 3-year period. And the average award amount has been around $680,000. We do support innovative community-based healthcare workforce training projects that do focus on increasing culturally responsive workforce in medically underserved and rural communities and addressing workforce shortages. So next slide, please. This is a little bit of a nice table to kind of break down. We do have our 3 rounds between 2019 and 2022, with our 4th round, I believe, was just announced and is on the website. And there's kind of a breakdown between new workers trained. So we have about 345 new workers trained across multiple disciplines, from traditional healthcare workers to nurse practitioners. We've also have it broken down by incumbent workers trained with additional skills. So we have a lot of different training. So that 666 number, which is, I know, pretty ominous, but it is kind of multiple various trainers. So there's a little bit of duplication across those because of the different types of training opportunities available. And then at the very bottom, we do have some high school students that were participating in a pipeline program for dental career exposure. And so we had about 32 participants in that program as well. I'm going to give just a second to look at that, and then we'll move on to the next slide. So our how-to expansion efforts, we are working to include a more streamlined equitable application process in this next funding cycle. We've provided grantees with additional technical assistance and support to address health equity, anti-racism, and trauma-informed workspace issues. We've enhanced a communication plan in order to reach a wider breadth of providers and organizations. We have, I think we're in the midst of finalizing the recruitment for a how-to advisory committee to include a more diverse representation. And we've started to develop standardized metrics for semi-annual reporting. So just some of the things we've been working on, and that Melissa will continue to do in her new role as the program coordinator. So now I think I'm going to pass it back over to Neelam. Thank you.
Oops, got to take myself off mute. Thanks so much, Jill. Now I'm going to provide an overview of the various behavioral health workforce incentives. And again, this is just data of funds that were dispersed as of June 30th, 2022. Next slide, please. So, again, you may recall that the Behavioral Health Workforce Initiative, passed under House Bill 2949, was the first of a series of historic investments in addressing severe workforce shortages in behavioral health, and also expanding diversity. This incentive during the reporting period started with loan repayment. And again, this represented a transition of the behavioral health loan repayment incentive that existed previously under the Healthcare Provider Incentive Program to this new funding source in April 2022. During this reporting period, one cycle was awarded of almost $1.7 million to 25 practicing professionals, both certified and licensed professionals. You'll see in the table, it includes some of the disciplines, and then over 1/2 of recipients identify as people of color or from tribal communities, and close to 1/4 speak a second language. Next slide, please. And then the $60 million was devoted to a variety of different incentives. $20 million was devoted to clinical supervision. This incentive was intended to provide supervised clinical experience to associates or other professionals to gain credentials so that they could practice. This incentive had one cycle of awards in February of 2022. They made grant awards to 21 agencies for 212 supervisees to receive supervised clinical experience. And that table on the right shows the range of agencies that received these grant awards and the grant award amounts. So the agencies awarded included culturally specific, culturally responsive, and rural organizations. And then, this incentive did not collect race, ethnicity, or language data. Next slide, please. And then the behavioral health workforce stability grants. These were launched under House Bill 4004, passed in last year's short session, which distributed just over $132 million in provider grants to address really some of the immediate workforce crises that were being experienced in behavioral health. These funds were specifically devoted towards staff compensation and workforce recruitment and retention. At least 75% of funds had to be used for wages, benefits, bonuses, and incentives to hire or retain staff. It directed OHA also to provide nurses and behavioral health specialists to bolster pandemic-related workforce shortages and to seek federal funding. And this incentive also did not require race, ethnicity, language, or data collection. Next slide, please. And so then I'm going to hand it back to Jill, who's going to go over the last incentive.
Thanks, Neelam. Had to get myself off of mute there. So the last one we're going to talk about is the rural medical practitioner tax credit. And we can go to the next slide for that. So again, this has been offered since 1989. So again, this is another much older program that we have. It allows eligible providers working in rural areas to receive a tax credit between $3,000 to $5,000 annually. The Office of Rural Health is our partner in crime on this one as well. It determines eligibility. And then we also partner with the Oregon Department of Revenue to confirm and process credit. And over the past 10 years, credits have been provided for over 4,300 providers for an average of 7 years. And the number of eligible providers has declined slowly, and we have not been able to collect race or ethnicity data for this program. On the table on the right, you'll be able to see kind of the eligible recipients by provider type. And it kind of has a breakdown there, and then the eligible recipients by tax year, and this is between 2018 and 2021. So pretty small little slide on that, but I think I'm gonna take it back over to Neelam to talk about our lessons learned and considerations going forward.
Great, thanks, Jill. Next slide, please. So some of the lessons learned include that high demand exists for loan repayment, as evidenced by our request to you to increase that in the funding allocation towards that incentive during last month's meeting, and then also your August meeting. Also, high demand exists for loan forgiveness and scholarships. These incentives are effective tools to address student debt burden, which is disproportionately experienced by people of color and people from communities experiencing inequities. Another A lesson learned is partnering with practice sites serving communities of color and other historically marginalized populations to continue to evolve the reach and impact of incentives is critical. And then, you know, we touched on this, that the impact of racism, bias, and microaggressions on incentive recipients is significant. And that, you know, the collection of race, ethnicity, and language data expanded to other incentives during this reporting period. And that collection of Real D compliant data will start this year. Next slide, please. So then considerations going forward, you know, we are working with our partners at the Office of Rural Health to try to collect more uniform data across these incentives, you know, given that they are, you know, different, and really to expand to Real D data, as well as when more information is available on sexual orientation and gender identity as well. We also have been working to create an anti-racism approach to recruit, support, and retain providers, and to develop trauma-informed workspaces. You know, another important consideration is considering additional incentives. There is very high demand for housing, particularly, you know, in some rural areas, as well as, you know, some of the urban underserved areas, and then continuing to create new options, which you'll see reflected in some of the legislation that's been proposed during this session. And then, you know, this was also a theme in our healthcare workforce needs assessment, that additional work around resiliency and well-being is needed. And then another theme also through the workforce needs assessment was the need to really create more intentional career pathways and advancement opportunities, especially in certified and uncertified occupations, and for those who want to remain in the field. And so next slide, I think now we're at the point for questions and comments. And then Mark has a slide also to go through the remaining administrative expenses questions from the last meeting. So Mark, do you want to go through those, or do you want to? We can pause for questions as well.
I think it's certainly up to the board. I'm happy to go now.
Oh, Mark, you're kind of difficult to hear.
Oh, thank you. Is this better, Kirsten?
That is better. Thank you.
All right, thank you. I'm happy to do either that the board would like. If you'd like to hear the follow-up to the questions last month, I can certainly go now. If you'd like to take time to respond to the evaluation highlights, I can wait.
I would suggest that we pause here, ask our questions. There is like a you know, this particular evaluation requires a vote of approval from the board. So let's pause here, reflect on this, and consider action that the board needs to take. And then we'll continue. And thank you. I really appreciate you coming back with that responsive information, and we'll delve into that next. So if board members have any questions for our presenters on this workforce evaluation, Melina, go ahead.
Yeah, hi, thank you for the presentation. I first have to say that I have a conflict of interest, and so I will excuse myself from voting, as I am a provider and have applied for the healthcare provider incentive program, and also have received the rural tax credit as a provider. But I would like to voice my approval, and I hope everyone supports this program and acknowledges the importance of it. As a nurse practitioner, there's not a lot of financial incentive to go from a registered nurse as a some are associate's degree and some are bachelor's degree prepared to go up to a master's degree or doctorate degree nurse practitioner. And so having the loan repayment is so important. And getting more people of color as a Latina, I think it's so important to have culturally appropriate care and to serve people in my community. And this program can just decrease some of those barriers. And so I just wanted to stress my my support of this, and I hope the board can acknowledge that. And thank you for your presentation. Oh, sorry. And one question to follow up. It was, I would love to hear more about how you plan to go forward on the anti-racism approach and plans going forward with that. Thank you.
Sure, thank you so much. It's always wonderful to hear from someone who's benefited from some of these incentives. We are kind of at the early stages. We're, planning to introduce perhaps some affinity groups that, would support providers. Also thinking about producing some informational materials. We're also planning to, look at some accountability measures as well that potentially could be instituted. So, a range of different options, and we intend to work with, the provider work groups that we've convened to help advise us on, structuring that response. And we want to make sure that, we're using all tools that are available.
Thank you. John?
Yeah, gosh, as I read this report, I thought back to all the times that you all have presented at the Oregon Health Policy Board. And this report just really impressed me with the numbers. It's just kind of more far-reaching and seems more efficient than I had really realized. And so I think it's a very powerful report. I also think that the numbers in which you're able to mobilize Real D and SOGI data and give us a sense of how this was being targeted, if you will, to be more diverse, were very effective. One thing that I didn't quite understand, I mean, tax credits are real money, and having gotten some of those back in the day, it seems like, especially since the Revenue Department is involved in that, somehow that could be quantified and be added to the impact of this. And then the other issue, as we went along, I think you're going to deal with, which is it would be nice to have some sense of what were the administrative costs of these various programs in terms of getting a sense of efficiency. But oh my gosh, when I look back at how much money was mobilized here over this period of time, what an impact you all have had. You should be very proud of that.
Thank you so much for your really kind comments. I don't know, Mark, if you have any. I know you had gotten the data from the Department of Revenue. If you have any more information about that.
Sure. John, thank you for the suggestions about doing more of a quantification of the impact of the tax credit. One thing that we do know is that there's a fairly sizable overlap between the rural medical tax credit and health providers who are taking advantage of some of the other incentives. I think what we could do though is we could go back to something we did maybe 8 or 10 years ago with an estimate of the return on investment of physicians in rural communities as one way to try to quantify the tax credit, which is available for physicians and for nurses. So we could look at that in the future. We did provide the total number of recipients of the tax credit, but I think with your suggestion, we could do more in future evaluations, certainly. And we could also do a follow-up and offer a couple of other thoughts in terms of additional impact from the tax credit beyond what's in the report.
Thank you. Bill?
Great. I want to thank the team for this great presentation and very detailed report. It's a very impressive program with very impressive results. Appreciate your sharing this information with us. One thing I was looking for, but didn't see in the PowerPoint presentation and my quick review of the full report, perhaps there, and I just missed it. But when evaluating a program, I assume we want to look at the goals, the original goals for these programs versus the results. And so I see, like on slide 6, 3,585 recipients. Is that more or less or about or equal to what the original goals were for these programs? Not asking for a necessarily detailed answer right now, but at some point it would be helpful to see how is this doing, how is the program doing compared to what was originally anticipated or planned or hoped for when these programs were created. So if you could provide that information at some point, as long as it's not too much detail, or if you can point to that information that's in the report that I missed, we would appreciate that. Thanks.
Thank you for the question. There isn't goals, and I don't know, Mark, I know you were, you know, as the longest member of the team serving at OHA. I don't know if you have any perspective or thoughts on that.
Neelam, thank you. And Bill, yeah, thank you so much for the question. When this program was initiated back in 2013, and the Workforce Committee and the board both had a major role in the development of this program and the legislature's decision to create the Healthcare Provider Incentive Program, as well as future other incentives that have come along since. Largely the goals, there were not clear metrics, but largely the goal was to stabilize the workforce and to expand the workforce, particularly in those areas which seem to be hardest to recruit and retain health professionals, largely in rural Oregon, but not exclusively. Also, certainly for OHP client, large populations and communities of color. And I would point to the areas of unmet healthcare need and those maps that demonstrated how the workforce in particularly underserved areas has grown or not grown over time as one of the metrics at the beginning of this process. It was seen as a way to determine, are we using these public funds to help shore up the workforce that we need in these areas that historically have had trouble finding it? But we can certainly respond to a greater detail, Bill, to your question and a follow-up. And thanks for that question.
Thanks very much.
Great, Oscar.
Thanks, Kristen. I have 3 questions. Hopefully by the time I get to my 3rd question, I still remember what they all were. But first, I just want to say thank you again for the great presentation and the thoughtful report. I really appreciate sort of the follow-up information, particularly the breakdown on race and ethnicity demographics. First question is maybe even for Jill. I think there's a slide that talks about the how-to funding rounds 1, 2, and 3. I was curious about, the sustainability of some of these efforts. Have they was a program that was founded on round 1? Is it still going? Is it still like moving forward? Was it able to sustain itself? Even if you don't have all the specifics, just anecdotally, I'd love to know like if some of these programs are still here or if they didn't get funded in round 2 or 3, like what happened?
Thank you so much for the question. I'm gonna jump in and respond to that one, but I think the programs are relatively new. The first round was funded in October of 2019, and I think just 2 of the grantees have completed, and so they're still relatively in formation, and the pandemic caused some setbacks and some no cost extensions. And Mark, I don't know if you wanted to add anything onto that.
I think that's spot on, Neelam, that 2 of the 3 original awardees or grantees have completed their program. Those programs have made a demonstrable difference, and we can provide individual project data as well. I want to emphasize that the projects are funded for a multi-year duration. So generally 3 years. It's not a matter of that they're either going to be funded for a second year or a third year, but if they're awarded for a full 2 or 3 year project period as they apply for. Hope that's helpful.
Yeah, maybe just for future, as you're getting more like impact, kind of like some of the questions that Dr. Santa was asking about is really about like how do you measure the long-term impact and sustainability of these efforts, even when the how-to funding has run out. My other question was, there was a slide around some of the areas in the state that were showing some progress in terms of staffing. I think a couple of areas that looked promising were Clatskanie and Cottage Grove. I was curious if, there's some either more like deeper analysis in terms of like, what are those areas doing that have created a little bit more success than others, to potentially share some of those lessons with other rural areas.
Yeah, we could definitely look into that and get back to you, Mark. I don't know if you have any initial observations based on your knowledge.
Not really, Oscar. You're right to note that 6 areas improved, 7 areas despite infrastructure challenges and COVID declined, unfortunately, and 3 remain the same. But the idea of sharing best practices and really getting in to see what brought success is a wonderful idea that I think we want to take to our team now that we've got really, again, a full complement of folks in the primary care office.
Great, thank you. And promise my last question, and I think I still remember what it is. There was a slide that talks about, so 4 culturally specific organizations getting funding recently. And then, several other culturally responsive organizations being funded as well. Out of the culturally specific organizations, can you sort of talk about like, are those funds being particularly targeted towards like 1 or 2 communities of color, or are you able to reach multiple communities of color so that there's more targeted and intentional strategies for multiple communities of color?
I believe the slide you're referring to is the behavioral health initiative, the clinical supervision slide. That was data that our colleagues in the behavioral health workforce initiative provided to us. We don't have a lot of the underlying information, but we'd be happy to research it and provide you with that in a follow-up.
Sure, that'd be great. Thank you so much.
Great. Thank you for the excellent questions, presentation. And I also want to acknowledge that there was so much in the detailed report that I really appreciated, and the work behind it, right? Thinking about the geographic distribution of these assistants. And that was really wonderful to see. The qualitative notes in addition to the data was a wonderful, kind of very enriching touch. That I appreciated, and you know that I love the acknowledgement of career pathways for licensed and unlicensed, or clinical, non-clinical people, which is great. I had one question, just because, I mean, you call out in your report the importance of retention, and that, you know, we fund people to stay in these communities, and there are challenges to their work. And so I think about our workforce needs as needing to address development and retention. And so to that end, I was wondering if in the analysis, there's any effort to track kind of, are people staying in Oregon after their 3-year requirement is up, or things like that?
Yeah, that is a great question, something we've talked about within our program. And we could definitely look at healthcare workforce reporting data to track and see, particularly with licensed professionals, to see if after their service obligation period ends, whether or not they've stayed in Oregon. So we could definitely work with our colleagues in that program and get you more information about that.
Yeah, I think that'd be fascinating to see that return on investment. Are we paying for a defined period, subsidizing a defined period of service, or are we investing in a longer term solution? And it probably varies significantly, of course, because these are all individuals with their own lives and dreams. But thank you so much for the incredible work that this represents, and for this important kind of retrospective, especially as the state considers, I think, again, in this, I would imagine in this upcoming session, like how we really are working towards more sustainable and effective healthcare staffing. So this evaluation does require a vote of approval from our board. Are there any motions?
This is Brenda. I'd like to move approval for the Healthcare Provider Incentive Program report.
Any seconds? That motion?
Second.
Thank you, John. All those in favor of approving the HCPIP evaluation report, say aye.
Aye.
Aye. Any opposed? Any abstentions?
Abstain.
Thanks, Melina. Great, thank you. And now we are running a little short on time. Need to move to our government relations people before they need to leave. Mark, I'm wondering if we could come back to these administrative updates later in the meeting or by email. You're a busy person as well. Sorry.
Happy to do that. I have the whole board meeting blocked out, so happy
Great.
to be available whenever.
Thank you so much. Okay, so then next I would like to introduce Ashley Thurstrup, Director of OHA Government Relations, along with Matthew Green and Phil Schmidt, both policy analysts with OHA's Government Relations. They're going to give us an update on the 2023 legislative session, and today's presentation update is labeled 4.0 in the OHA legislative update in the meeting agenda, so you can click on that. Thank you, Ashley, Matthew, and Phil. Begin when you're ready.
Great. Thanks so much for having us here today. We're really grateful to be here. I'm Ashley Thurstrup. I use she, her pronouns. I'm the interim director of the government relations team here at the Oregon Health Authority, and I'm joined by Matthew and Phil. Would you like to introduce yourselves? Matthew,
Sure,
I'll go to you first.
Go Phil.
Sorry, Philip Schmidt, I use he, him pronouns, and thanks for having us.
And Matthew Green, working on a lot of budget issues and communications for the GR team.
Great. So today, what we're hoping to do with you all in our short time together is to outline OHA's legislative priorities and note some key bills, which you'll likely be interested in as they impact the health of people in Oregon and the work of OHA through transformational changes to OHP benefits, to address upstream drivers of health inequities such as homelessness, work to ensure health coverage, and also bills related to expanding and stabilizing behavioral health and public health, as well as workforce. So we are planning to share this information today about the policy option packages that were identified in Governor Kotek's recently released budget. I understand you're going to learn more about that a little bit later from Dave Baden, so we won't dive in too deep. And then we're also going to share the legislative concepts that OHA developed and proposed that have been greenlit by the governor's office. So some of those have been introduced as bills already, and then some we're working on, and they'll be introduced shortly. And as a reminder, OHA as a state agency has not taken a position on any of these bills that we're discussing. Could we have our slides pulled up? Thank you so much. Great. You can go to the next slide. So here for your reference, you'll have the list of the entire government relations team and the portfolios, and we really have that no wrong door approach. So reach out to any one of us and we'll make sure to connect you with the right person. If you have any questions after today's presentation or just an interest in understanding a little bit more about a bill. Next slide, please. Great. So before session, we worked to develop these legislative themes and ideas that we're going to share with you today. We really strived to do this through a collaborative process with community groups representing people in Oregon most impacted by health inequities, providers, counties, community partners, tribes, boards such as the Oregon Health Policy Board. And we've grouped these under the legislative themes listed here. So the first being our North Star goal around eliminating health inequity by 2030. That we continue to make headway on this goal, thanks in large part to the work that you're all doing here at the Oregon Health Policy Board as well. So while health equity really runs through all the agency and governor's health proposals, this theme is really important to call out on its own as well. So this work of health equity is, and the work that we're going to see in the session, or that we are seeing in this session, is really building on the health equity infrastructure within OHA, with our providers, with our community partners, and by further implementing health equity strategies and activities throughout public health and the entire healthcare system. It's about listening and working together to address the needs of communities most impacted by health inequities, and by using data, partnering with counties, providers, regional health equity coalitions, tribes, CCOs, and really working together in a collaborative way. The second theme here, and you'll see when we get into it, the bills are all structured through these legislative themes. This goal is about stabilizing the behavioral health system and supporting communities across the state to collaboratively develop a behavioral health system of care that meets the needs of people who are struggling or in crisis. We know the recent investments made in the 2021 and 2022 sessions are only really beginning to take effect, and we're starting to feel those now, but there's more resources needed to build out the strong continuum of behavioral health supports in communities, and really including residential treatment. The next goal here is focused on the Oregon State Hospital operations. So working together again with community mental health providers, judicial experts, and others as we continue to implement Dr. Peinel's recommendations related to the Mossman Judicial Order, pursuant to the populations that are there under aid and assist and civil commitment, and really working through some of the wait times that we're seeing in communities. Protecting health coverage is a very important theme. Throughout the session, you'll see that many bills have been introduced, and you'll see this show up in our the governor approved budget as well as the policy option packages, that we're very focused on maintaining the gains in coverage for all the 1.4 million people that are enrolled in the Oregon Health Plan as the federal pandemic emergency, public health emergency ends in April. So the work is really to ensure that people with fluctuating income or who are right there at that income line, working families who move off OHP have affordable coverage options and are supported in maintaining coverage. We're also focused on implementing Oregon's groundbreaking 1115 Medicaid waiver to fulfill its potential to implement many of the root cause and address many of the root cause problems that undermine health and quality of life. We have a goal and a theme here around working to build a post-pandemic public health system. This work is focused on supporting and preparing for future pandemics, disasters, as well as addressing reproductive health, prevention of chronic disease, suicide, alcohol, other drug misuse, and then a strong focus on ensuring counties and tribal governments and other partners are prepared to help modernize the state's public health system. And then the last goal here is really around promoting and partnering on housing access. And this is a key goal as well for Governor Kotek. Focused on collaboration with counties, nonprofits, working closely with the Oregon Housing Community Services to reduce houselessness by leveraging federal funds from the 1115 Medicaid waiver and other sources to add more housing capacity and improve the health of our communities. So I'm going to pass to Matthew now to begin talking about the policy option packages and associated bills under the theme of health equity.
Hello, and there are so many things on the next few slides that we're going to go through them very, very quickly, each one. And so we're happy to take questions at the end or after this meeting sometime if you want more follow-up on any of these. So this is some of the budget items related to health equity. POP there, for those who don't know, it's policy option package, basically just budget request. So this is some money both to do internal infrastructure at OHA and also to help externally, both with the Real D and SOGI data to help providers who have to provide that, give technical assistance to them about how to provide it, and also standing up more regional health equity coalitions around the state, which have been very popular and requested. Next slide. And we have a couple of bills that fall into this category too, LCs, or now they're bills, I should say. One is on the Real D and SOGI data, which currently under law is not considered medical records that are private. So this would clarify that that data is confidential, that you can't release identifiable information there, although it still would be available for larger public health information, so forth, aggregated data. And also one where we have a longstanding program through OHP, the Oregon Health Plan, about we actually get federal funds that are specifically directed to tribes to provide medical services to their tribal members. And this is 100% FMAP really means the feds pay 100% of it. And this program, it's something we can do under federal rules, but it is not yet in statute. So tribes have asked us to codify it. So next slide. Here's a couple of the big public health funding issues. And the biggest one is the public health modernization. This is an extension of what's happened in the last couple of biennia about putting money into remaking the public health system from what I'd like to call the disease of the week model, where we get one grant to talk about one particular problem that a local health department would have to have a program on X illness, and instead transform it into a whole system. And a lot of this money is going to the local community, so a local system in particular that can address infection control, can address surveillance for community issues, can address education and outreach on a broader scale and much more effectively. And then the personal protective equipment one here, this is a stockpile one. This came obviously out of the pandemic, the idea of having a stockpile of medical supplies. And we have authority to do it now, but we don't have the money to actually have the supplies yet. So that's this request. So next slide. And a couple of other public health bills. the pharmacist flu vaccination for all. Right now, pharmacists can give flu vaccines to patients who are 7 years of age or older. And often pharmacies are the most convenient place for, say, a family to go to get a flu vaccine. Now, currently, if they happen to have one of their children is under 7, they have to make another appointment somewhere else at a clinic, which is just one more obstacle, one more barrier to kids getting flu vaccines. So we're just trying to take care of that. The last one here, the Death with Dignity fix. The Death with Dignity Act currently requires that the patient be a resident of Oregon, and there was a lawsuit around that, and this is a settlement of the lawsuit to remove that residency requirement. It would still require that the physician, the provider involved in it is licensed in Oregon. That would not change. So next slide, I think we're going to turn it over to Phil for a few minutes.
Yep, thank you. And we are switching gears slightly to funding requests that are in the governor's budget. So these are not bills that we're introducing, but instead this is funding requests, as I said. So the first is a funding request around the 1115 Medicaid waiver and implementing it over the next 5 years. And this committee has had several presentations over the past now several years, I think, on this topic of the Medicaid waiver and its focuses. So we're pleased that the governor will be requesting funds for us to implement this. Groundbreaking agreement with CMS and begin to draw down actually over $1 billion in federal funds that will help support Oregonians in transitions and in other ways in the Medicaid program. Another policy option package or funding request that the governor has included is around redetermination in the basic health program. They are sort of split apart in the governor's budget, and there's funding requested to make sure that we're able to achieve our goal of keeping everyone who is currently covered by the Oregon Health Plan covered during the redeterminations process, which again, I believe you all heard about. But starting April 1 of this year, we're going to be going through the Oregon Health Plan membership and redetermining folks' eligibility. And there's an estimate that several 100,000 folks will no longer be eligible. And we would, our agency and our cross agency, we're working on this with the Department of Human Services. Goal is to keep everyone in coverage that we currently have covered, whether that's moving them to the marketplace or other tools. So we're pleased that there's funding for those efforts in the governor's budget. We can go to the next slide. In a similar vein of protecting health coverage, we do have an LC that is being introduced as a bill. It's been greenlit by the governor. So the bill number is to be determined, but it would focus on implementing the bits of the waiver that require statutory changes in Oregon. One of those that this bill is really focused on would be changing the metrics and the metrics program to raise up community voice and better focus the metrics that we focus the CCOs on health equity. I think we could go to the next slide. I'm trying to go quickly here.
Phil, I'll jump in on this. So this policy option package, the first one here is around 988 expansion in the Oregon Behavioral Health Crisis System. So this is really about expanding and enhancing Oregon's 988 system and declaring a state of emergency for Oregon's struggling behavioral health crisis system. So it includes enhancing existing services and expanding our current system to a no wrong door approach through the statewide 988 call center, mobile crisis team outreach, and developing a seamless continuity of care through follow-up service referral and tracking. And then the POP 402 is around Oregon State Hospital sustainable staffing. So this policy option package provides investment and redistribution of resources to build a successful and sustainable infrastructure necessary to advance efforts towards supporting and sustaining staff and patients within the Oregon State Hospital, and working towards those goals that we have around health equity for the people that are cared for at the Oregon State Hospital. Next slide, please. Great. So aid and assist, so a major piece here of legislation, Senate Bill 219. This legislation implements the changes to the aid and assist statute pursuant to the recommendations from our neutral legal expert related to the Mink-Bowman-Mossman litigation. It includes clarifying that the county transportation related to people who need to return back to the county upon discharge. It supports the cadence of evaluations submitted to the courts by forensic evaluation services every 30 days for the first 90 days, and just works on ensuring that the timely discharge so that people can work through the judicial system as needed for folks that are there to maintain or regain mental clarity for aid and assist, being able to aid and assist in their own defense. And then the LC 502, which again, this bill hasn't been introduced yet, so it's a TBD at this point. This is about ensuring that payers and insurers cover the cost of behavioral health crisis in Oregon. So all payers beyond government healthcare programs, but including commercial insurers, and then anyone who provides health coverage would need to cover crisis walk-in facilities, evaluation and treatment, outpatient crisis, and medically managed or medically monitored withdrawal management services, as well as mobile crisis teams. So we expect that this will help sustain coverage of behavioral health crisis service costs. Next slide. I know we're moving pretty quickly through these. So again, our team is available for any follow-up questions that you all have. So we wanted to list some other, these are non-OHA bills, but these are bills that you might all be interested in learning about. House Bill 2544 increases the statewide capacity of licensed residential facilities serving individuals with substance use disorders or mental health concerns. This is Rep. Nose. Rep. Nose has introduced this, and it's currently in the House Behavioral Health and Healthcare Committee. In fact, most of these bills are, and so I'll just note if they're not. House Bill 2461 imposes new requirements on Oregon Health Authority with respect to residential mental health services, and it specifically adds that mental health residential services need to be provided by CCOs beginning January 1st, 2025. House Bill 2462 and the companion bill, Senate Bill 624, established Certified Community Behavioral Health Clinic. It's a program that would be run by OHA. House Bill 2729 requires OHA to develop, implement, and administer a program to support consumer engagement efforts aimed at increasing and optimizing consumer involvement in planning and decision-making around delivery of behavioral health services in the state. House Bill 2757 expands and provides funding for coordinated crisis service system, including 988 suicide prevention and behavioral health crisis hotline. So to what I just talked about earlier. House Bill 3126 establishes emergency behavioral health services for children and be a new program at OHA. And then House Bill 2540 establishes a board of behavioral health specialists. It would amend statute relating to psychologists, therapists, social workers, licensed professional counselors, and places restrictions on who may practice child behavioral health and authorizes other currently licensed providers from other health regulatory boards to also practice child behavioral health. So in addition to the bills listed here, I want to just note that there are also bills related to civil commitment and jail diversion services, harm reduction, naloxone, suicide prevention, behavioral health facility investments, and then expansion of behavioral rehabilitation services for youth. So there are a lot of behavioral health bills and too many to go through today. And I'm going to pass to Phil to talk about the cost growth target bills.
Thanks. Yeah, I'm just going to briefly mention, that it looks like we're going to have a conversation around the healthcare cost growth target in the legislature. There's 3 bills that you'll see on your screen, which would modify or significantly change the healthcare cost growth target program. And without speaking for those who are proposing these bills, I think that most of the interest is in how the program measures and adapts to things like high inflation, workforce costs, staffing costs, and other sort of unforeseen shocks to the economy and therefore the healthcare system, in addition to sort of how within the program things are measured. So we'll be looking forward to that conversation and giving information about how the program is set up and how it has been approaching these topics. Maybe we can go to the next slide. There are a few others. The first, requiring Medicaid to make a per diem payment to hospitals for patients they cannot discharge. This was up in a committee yesterday for a public hearing, and it's really at a minimum a conversation starter about the difficulties that hospitals in particular are having with patients that they cannot discharge for reasons related to lack of a placement, or the person has multiple co-occurring issues that make it very difficult to discharge them, and hospitals believe that because they are unable to receive payment during the time that a person is boarding, that they should receive some sort of payment from the state for these patients. Again, a conversation starter at a minimum. The next is another conversation, which is sort of a step forward in the healthcare transformation journey. And I think that the best way to think about the Aligning for Health pilot program as conceived by the bill's sponsors is it would be starting to push the CCO model into a multi-payer space, so that commercial Medicaid, PEB, and OEB perhaps would all begin to pay in the same way in a given region in the pilot program. So an interesting concept with a lot of layers that we're tracking and actively contributing to in the form of information. And I think I'll skip the last one because it's about DCDS. And so next slide. Yeah, you all just had a fabulous presentation around healthcare workforce, and the legislature is really paying close attention, and there's a wide number of bills that would be addressing the workforce challenges that currently exist. This is a non-comprehensive list of some of those bills. There have already been hearings about bills relating to this topic, and I think we sense that this will be a theme throughout the legislative session as the legislature really grapples with how Oregon can meet the needs of the communities that the healthcare system serves, and begin to address some of the challenges that patients and their families face and providers face as we deal with these workforce shortages and mismatches. I think we go to the next slide. I think this is me as well. So, we, as always, we also have a wide variety of bills that, would presumably make changes to how how Medicaid and medical assistance serve folks in Oregon. We are, tracking these. I think one that you may want to note is the second bullet on the left, which is HB 2446. Extends the contract between OHA and CCOs through 2026. So that would, in essence, push back CCO 2025 by 2 years. So I guess it would become CCO 2027. there's also a bill that would make the CCO contracts 10 years in length rather than 5 years. But I think there's going to be conversation about that and how the CCO contracting process works. And I think a lot of that's stemming from wanting to understand how we implement the waiver and how CCOs can incorporate those changes into their contracts and I guess all the other things that are current that you all have been hearing about that are kind of currently affecting our Medicaid program. I think I'll stop there and we have the next slides around key dates.
Mm-hmm. Yeah, just a couple of final thoughts. We are still very early in the session. The dates there about deadlines, that's when bills, if they don't make it through, they die. So we'll get a better sense of what's actually moving by those and hopefully end in June. And the next slide, just for information, this is the site that the government relations team uses all the time, OLIS, that has all the information about all the bills, all the committees, all the hearings. It has videos of the hearings during and after. It has all the amendments. It has everything you're interested in. So that's it for our presentation, and have you take questions.
Any questions from board members? Alina.
Yeah, I just wanted to say thank you to Ashley for using the term medically managed withdrawal versus detox. That's just one step to decrease the stigmatization of addiction and treat it as a chronic disease. And also, I'm happy to see a lot of House bills supporting expansion of residential detoxes, or sorry, facilities. And last I heard, there was only one Spanish-speaking residential facility in Oregon, and that's in Madras. And so it's definitely a need. Thank you.
John?
Yeah, I was surprised to see this bill about parity in behavioral health coverage by payers and insurers. I naively thought that a lot of that had been solved, and it sounds like not. I find that disturbing, that there's payers who are avoiding stepping up to that. So I need to learn more about it, but that just surprised me.
The issue there is specific to, there might be other issues, but this one's specific to the crisis care system, behavioral health. You know, if we have a mobile crisis response, someone goes to the local community mental health program for kind of crisis services there. What apparently where this grew out of is that in Washington State, which is just a little bit ahead of us in this process, they found that providers were not considering that part of their treatment, that services that they cover by their basic insurance. So trying to head that off.
I mean, I hear that, and I thought again that if there was a medical benefit for something, and there was an equivalent service in mental health, that payers had to cover that. So in order to have parity between the two, I mean, as you've just explained this, well, it sounds like, well, on the medical side, I think emergency room and urgent care and things like that have to be covered on the physical medicine side. How are they managing to justify not doing so on the behavioral health side? I mean, maybe that parity legislation from years ago isn't strong enough. I mean, we've been through this discussion culturally, and I thought we had gotten insurers and payers to agree to that. It's just unfortunate.
Yeah, unfortunately, I can't give you more depth of detail on that point. We did get some advice from DCBS that was still an issue under exactly the statutes you're talking about.
Thank you.
Oscar?
Hi there. Bear with me as I try to craft my question, which is probably tricky and also could be connected to a later part of the presentation today about the CCO contracting. I also was, I was kind of intrigued by House Bill 2446 about the contract extension on the CCOs. And obviously, in the last few meetings at the board, we've had conversations about the contracting process. We have another presentation later today, which unfortunately I'm not going to be able to participate in because I'll have to step out early. These are all things that are also conversations that are coming to the board. And I imagine that even the board is still trying to really wrestle with our thoughts about a extension or not. And then this idea about potentially extending the contracts to 10 years instead of 5 years. I guess my question is like, what, and maybe it's okay that sometimes the Oregon Health Policy Board has different ideas than some of these bills that are being introduced and led. But yeah, just kind of curious to hear your thoughts around what does have, like, what is like, your thoughts around some of these bills being sideways with where the board is at. And also, again, I think we've mentioned before, there are some bills in here that are really particularly interesting, like the bill around the adding consumer voices to behavioral health services programs. Those are like, alternatively, there's also these really great bills that I think we've had a lot of conversations around, like elevating consumer voice, elevating other voices. So I guess, like, what are your thoughts on sort of the differences, and then also like, how can the board be supportive when we're really excited about certain things?
Bill, do you want to jump in?
As far as the CCO contracting, I saw Dave Baden come off mute and would love to defer to him to sort of give some thoughts if he's willing. And then I think as far as how the board can weigh in or support, I mean, I would have to defer sort of to the board itself actually about how y'all would want to process your interest in certain bills and topics. But Dave, do you have any thoughts on the CCO contracting bills and conversation?
Thanks, Oscar. Dave Baden, everybody. You see him pronouns Chief Financial Officer at the Oregon Health Authority. Good to see everyone. So, yeah, Oscar, it's a really it's a really good question. And then just like from the authority's perspective, I think Director Schroeder talked a little bit about, sort of conversations and just feeling honestly a lot of pretty overwhelming tasks upon the agency to get done, whether it's implementing historic provisions in the waiver to redetermining 1.4 million folks on the Oregon Health Plan and try to successfully get them to the place that they need to be, and getting sort of ready to go for a contract procurement all at the same time. Even for a place that has helped manage through a pandemic, seems pretty darn overwhelming. So I think the feeling of, is there a chance to build then a little bit more time for both, honestly, consumers, the public, OHPB, and the legislature to talk about a little bit more of what some of these things are leading to? Because I think, we're going to be putting big things into the CCO contracts to implement based on the waiver as we start into 2024, or different contracting mechanisms for implementing the health related services and supports, et cetera. So I think we've got a lot of things there. And I think really value and need that feedback of where a little bit, where are we sort of going, and building some things in there. I think we have some ability to do some of that extension ourselves. Obviously, we'll work with the legislature and answer questions about impact of what those bills are. And, I think to Phil's point, where OHPB feels comfortable in providing some of that same input, I think makes a lot of sense. But I think for the agency of how do we make sure that we're going to be building to the right spot for whatever we end up landing on for the next procurement. Hopefully that was helpful, Oscar.
Yes, thank you.
Okay, well, I think we are running 10 minutes late, but we're in need of a break. So let's take our 10-minute break. We'll return to public comment. And I'll see you all at 10:50.
And they're keeping track mentally of the different things that they're trying.
All right, board members, if you could rejoin the meeting, turn your camera on or send a little signal so that we know that people are back. That would be great. All right, welcome back from the break. Up next on the agenda is public comment. We have 2 commenters signed up to join us here today, and the Oregon Health Policy Board welcomes and deeply appreciates public testimony. It's one of the most powerful ways we demonstrate our commitment to profound listening and learning. And deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject or correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with that kind of careful attention, respect, and honor that you deserve. We want to acknowledge that, lost my spot, sorry. We want to acknowledge that we hold time in our meetings to hear public comments, and it's meant to provide a voice and perspective from that individual, and is not a representation of the Oregon Health Policy Board or its members of the Oregon Health Authority. Each presenter is given 2 minutes to share, and in the event that doesn't feel like enough time, we'll encourage you to provide written testimony that we do commit to reading. To help us keep on time, we'll start a slide with a 2-minute timer for each presenter, and we kindly ask that presenters conclude their presentation when the timer is complete. And please know that written and verbal public comments will be reviewed and discussed following each meeting by the board chairs and staff to determine the appropriate next steps. And board staff will communicate those next steps with each public commenter. So I'd like to welcome Kevin Fitz. Begin when you're ready.
Hi, good morning. My name is Kevin Fitz. I'm a volunteer with the Oregon Mental Health Consumers Association. I'm here to present the Oregon Behavioral Health Consumer Engagement Act of 2023. This is not an Oregon Health Authority bill. This is an independent community organization bill that purports to organize, educate, mentor Oregon health plan consumers in the behavioral health contingent. I want to say we've got into managed care, behavioral health got into managed care in the mid-90s with the promise that managed care was going to reduce or help manage acute care costs and pharmaceutical costs, and as well as integrate primary care and behavioral health care, as well as mental health care and addictions care. We still have a lot of those things are unfinished business. You were discussing earlier whether or not you should prolong the CCO contracts and bringing forth CCO 3.0. I'd love to have more conversations about that, but I think particularly in the areas I managed, I would give them barely a passing grade in the promises of managed care for behavioral health. One of the things that this piece of legislation does that's currently pending in the Senate and the House Health Committee is it engages the mental health consumer, the Oregon health plan consumer, about their benefits to understand whether they think the process is fair, just, and comprehensible. You will see probably some news about this Healthcare Engagement Act. This didn't come from the Oregon Health Authority, and yet I have not been able to engage any leadership in the Oregon Health Authority in even reviewing my bill. Which is most unfortunate. Oftentimes, the behavioral health consumer, individuals who live in poverty with psychiatric disabilities, are chasing the bureaucracy to make more room at the table. I am only one person, but there's 250,000 of us behavioral health consumers alone, and we hope that our voice is heard better in the future. Thanks for listening to my comments, and I sent you the document.
Thank you for sharing and sending that, Kevin, and for your advocacy. All right, next up is Michael Huntington. Michael, are you with us? Terry, do you know if Michael is?
Yeah, I'm here.
Oh, excellent. Begin when you're ready.
Thank you. With empathy, I witnessed you, the Oregon Health Policy Board, take on the redetermination task It must be stressful and wrenching to ponder who deserves or qualifies for care and who doesn't. Then you have to deliver the news to both the lucky and the unlucky. Oregon is getting closer to adopting an efficient and fair system that avoids the burden and cost of periodic redetermination. Senate Bill 704 will create a governing board for an Oregon Universal Healthcare Plan that honors the principles and recommendations of the Senate Bill 770 Universal Healthcare Task Force. I urge all Oregon Health Policy Board members to work with your legislators to approve Senate Bill 704. It will make your job much easier as it simplifies and provides better care for more people at a lower cost. Thank you.
Thank you, Michael. Thank you for being here today. Okay, Tara, are there any other people, or I believe that's all, but definitely don't want to miss anybody. Okay. Well then, our next agenda item is the governor's budget overview. Definitely looking forward to this one. Dave Baden, glad you could join us. Dave Baden is OHA's Chief Financial Officer, and he's going to go over the governor's proposed 2023 through 25 budget that was released last week. The budget is a strong indicator of the governor's priorities and commitments and where OHA can help support the governor. So today's presentation slides can be found in the agenda titled 4.0 Governor Budget Overview. And thank you for being here, Dave, to bring this exciting overview to the Oregon Health Policy Board. Begin when you're ready.
Great, thanks, Kirsten. Again, Dave Baden, Chief Financial Officer here at the Oregon Health Authority. I use he, him pronouns. Pleasure to be here today. Good to see everyone and happy to go through what I think is as Kirsten laid it out to be, a really good a good start for the Health Authority, a good clear commitment from Governor Kotek about the strong priorities, many of which we've worked so closely with so many OHP members and members of the public to build and get going, from a commitment to healthcare expansion to assuring that the 1115 waiver gets the resources it needs to be successful, to keep pushing for some of the expansions, including the basic health plan, and a variety of other ways. I think it is a really good budget for the Health Authority under sort of an overlay that going into the next biennium, the current economic forecast is for a slight decrease in overall revenue. So as we flash up slides here, thanks. I do want to put some context even on before we get to the first slide. I had the pleasure to actually work pretty closely with Governor Kotek and her team after her election and putting this budget together for the Health Authority and help in a variety of other ways. And it was sort of a tough picture to face right after election. One of the big things to get together is this first budget and all of the policies that go with it. So really facing some economic headwinds. I would encourage you to watch and listen to some of the state economic forecast. Is that I think there are some clouds out there. There may be some puffy clouds, not maybe big storm clouds of an economic forecast, but a little bit of uncertainty of what will happen in those clouds, right? What is this going to lead to? A very tough recession on the state in the future that could be felt in 2023, 2025, or will it be sort of a slight downturn to what has been a pretty robust economic forecast for the state the last few years? You could definitely see that reflected in the amount of money and resources that the Health Authority has received. Lots of federal resources, but then a lot of state resources to move out on a set of priorities that that I think we will continue to push, and that this budget really does think about. So maybe we can go to the next slide. So I'm going to flash up a lot of numbers and focus on a few areas. Please look forward to anything that I missed, or areas that are of particular concern in the OHA budget and what's being presented to the legislature. And again, just a reminder of where we're at in the process. This is Governor Kotek's first budget presentation. That just was released last week and now is in front of the legislature to deal with. As with any governor's budget, we'll see what the legislature ends up working through. Again, this is, as I think Kirsten said, really is a great placeholder and a great push for what we have and I think are important in health. So again, sort of in these a little bit of economic headwinds that are facing, with a general small reduction overall for state on the revenue picture, you could see that we have some pretty large percentage increases, both in sort of like as compared to last biennium. And I think one of the pieces of OHA's budget that makes it both complex but then hard to sort of do apples to apples comparisons is, there's so many inflationary factors and other things that get built into our sort of our base. So as we go from biennium to biennium, there's a lot of sort of various factors that are built into the budget. So I don't want to make too much into like big percentages, but there are a lot of both increase in the amount of positions that the health authority is asking for to implement its programs, and the amount of resources to get things done. A lot of this is in the Medicaid and behavioral health space. Some of that is just Medicaid, with even any sort of inflationary measures, gets more expensive on a year-over-year basis. So that takes a little bit of these percentages, but I will say for the variety of budget provisions that the authority asked for in its agency request budget, many of those are included. You could see here a lot of additional positions. A lot of those are going into the state hospital. So the Oregon State Hospital has a lot of new position requests for sort of building on some growth that happened in the last biennium to assure that there's enough staff to provide appropriate services in a changing environment 24/7, especially with differences of the patient mix that the state hospital is having to face now. So that is a big priority. Again, it fully funds OHA at its current service levels. That's I think for us showing that that what we have received in the past is that we're generally moving forward and keeping those things going. And I'll say from the priorities, as I look at what did get funded, I think comes in a few different areas. So investments in health equity. I think with a lot of push and partnership with the health equity definition, with things that we as a collective have been trying to do to eliminate health inequities in Oregon, to really try to change power dynamics, to focus on both internally to assure that OHA is working to become a more anti-racist organization. This budget really recognizes the work that has been done in the past and adds some expansion in some areas, both to assure that in a couple of ways in the Oregon State Hospital, there's really been in OSH one position really focused on setting up a variety of health equity programs that is expanded from 1 to 28. So this budget really provides a historic opportunity in the state hospital to focus on some areas and concerns that have really been problematic in the Oregon State Hospital around incidents, whether with staff, with patients at the Oregon State Hospital, and to provide a more robust unit to really work to assure that that there are specialized treatment and supports, that there's a a much stronger push to assure that there's training resources available for staff, and assurance that, if there are concerning incidents around race, that there's people available that are trained and ready to respond to those things that are happening. Continued increase in our Division of Equity and Inclusion. So I think there's a really continued growth and push in funding here. Protecting health coverage, I think I talked a little bit about these, signaling in the governor's budget for OHA to continue to work with CMS to try to negotiate a basic health program, to continue to push for a temporary expansion of Medicaid as we go through redetermination, so we can catch people that are 138 to 200% of poverty. So a continued push in the governor's budget to go that way, and obviously to really go all in the waiver, the 1115 waiver, including continuous eligibility as early as possible for up to age 6, and then 2-year eligibility for 6 and above. That is fully funded in the governor's budget, and a lot fully funding the health-related services work that the waiver talked about. So in behavioral health, lots of a variety of continued work, both continuing the investments that the legislature had done in this current biennium. Again, a lot of those were federal funds, so having to look for general funds to offset some of the federal funds losses. So really worked a variety of ways to do that. Continued work to roll out on the 988 system, work on some crisis, other behavioral health crisis response. Again, a lot of support on the state hospital. And finally, public health, a set of new funding supports for public health in its work. The biggest one being the governor's budget asked for $50 million to continue the public health modernization work through the public health division. Next slide. So a couple of things on the sort of, again, I talked a little bit about the economic headwinds. We did have a lot of federal funds that made this a really complicated budget to sort of backfill. I'll give you a good example. Some of the American Rescue Plan Act, ARPA money, that was a large amount of federal resources that was made available to all states. What Oregon chose to do with a portion of those is to basically swap out general funds in the Oregon State Hospital with federal funds. Understanding that in this biennium, we were going to have to swap them back. So that swap did happen, but that is a significant, that eats a lot of general fund that is available. And there's examples of that throughout this budget. Obviously, I did talk a little bit about inflation, that inflationary expenses are always a part of the budget build for OHA. This clearly has inflationary pieces that are in it. We'll talk a little bit about some pieces on the CCO side of providing inflation at less than 3.4% in a couple of ways. One other piece, again, on the health equity front and on the expansion of healthcare is around Healthier Oregon. So the current legislation that created this program in Oregon has basically at the end of June of 2023, there was a sort of a budget amount for this biennium that basically that trigger went off. So it said that it should go to a full expansion, but that we had only $100 million to provide that work, and so needed a lot of additional resources to be able to bring Oregon Health Plan coverage to those that would be eligible for the Oregon Health Plan, except for their immigration or documentation status. This is a big deal. I'm super excited that we're able to have enough resources to go live fully on July 1st of 2023 to allow basically all of people that are in Oregon that qualify will be able to move into this program and have access to healthcare fully, where they may not have had access to healthcare in the past. So really excited that this one is going forward. Talked a little bit about some of the other drivers here. Next slide. So a little bit on some of the reductions. So built in to the overall increase are a couple of pieces that are not sort of fully funded as compared to what we asked for in our agency request budget. So Medicaid inflation, this is true in CCOs as well as sort of fee for service, is recognizing that sort of utilization generally and sort of the trends over the as the health system is moving out of the pandemic and CCOs are moving out of the pandemic, that the governor's budget recognizes that as we move into 2024, is that that we are trending the budget of a 2.4% increase in 2024 and a 3% increase in 2025. So if you compare that against sort of the 3.4%, that does yield some savings that were then reutilized in various aspects around the health authority and around the state budget. Generally happy to chat more about that one. One other piece, and this is will have some impact. There's both some vacancy savings that are being realized at a higher rate, some long-term positions that have been vacant, that have been removed from OHA's budget, and some reduction in some internal service and supplies budgets. All of that does equal into some reductions in program. Again, the vacant position piece, I think if you look at budgets across state government, there's was a similar set of circumstances that we feel relatively confident by increasing the amount of vacant positions shouldn't harm programs. It's a challenging environment to hire, period. Definitely challenging the state government. So recognize that the vacancy rate may be a little higher than we want, but that is what is budgeted in this budget. Next slide. So I talked a little bit about these. So again, just as a reminder, we put forward policy option packages. Those are the wondrous term POPs. So those, so we had, a whole variety. I think we had 51 policy option packages that the agency put forward. And I think we are getting at least partially funded or fully funded about 35 of those as put in the governor's budget. That's frankly a amazing percentage. If you would have told me that we were going to have 35 policy option packages going forward, I wouldn't have believed you. So I'll take that as a big positive. These are good examples of some of the health equity related provisions that we're pushing forward to. The two I've not highlighted already, the REAL-D and SOGI implementation. This is really about bringing a better system for collecting this data writ large with health system, healthcare, hospitals, et cetera, to frankly get in compliance with statute. We're not there now, and we need to be there. We need better data to be able to make better decisions as a state. This will be a really big push to help us get there. The Regional Health Equity Coalition expansion is adding 5 new RHECs into the state. So sort of been an ongoing strategy and work to push in this direction, and the governor's budget recognizes that and provides or asks for resources to legislature to do that. Next slide. Again, talked a lot about these already. Full expansion of Healthy Oregon at $500 million. Medicaid waiver implementation for this biennium. This provides resources to focus on continuous eligibility, to focus on implementation of HRSN services, and a variety of other provisions included in the waiver. Ongoing development of the basic health plan. So I will say that the dollar amount recognizes that OHA is still negotiating aspects of these things with CMS, both the temporary expansion related of Medicaid as we go through redeterminations to be ready for a basic health program, basic health plan, but a full signaling in the governor's budget for OHA to continue that negotiation. That may lead us to having to go back to the legislature if CMS says, hey, yes, we agree with you, we are okay with a temporary expansion. We may have to go back to the legislature with some changes as we get those negotiations finalized. Again, the governor is signaling very clearly she wants us to keep going on that. One other one that is less about general funds is resources to assure that, to help, and there's a legislative concept also to transition from a federal platform to a state-based marketplace. So support for that in the governor's budget. Support for the healthcare market oversight program. These are some position and other costs that didn't naturally carry forward. Not anything new here per se, it's just positions and work to support the work, focusing on mergers and acquisitions and cost growth target work for the state. Next slide. So long list on behavioral health. As you could see, this is the and more on the bottom here. So a couple of things I wanted to highlight. Continued growth of acute psychiatric facilities in the community, recognizing that we are currently working through contracts to bring a lot of new beds at the community level across the state, but it's not enough, both in the core mental health pieces, acute psychiatric facilities, but definitely also in substance use disorder facilities. So a continued growth in that piece. The harm reduction clearinghouse. So this is not general funds, but a signaling to the from the governor and through the budget to the boards that are making the decisions about how that opioid settlements are used, to ask them to direct them to the harm reduction clearinghouse. So this is the free naloxone and other supplies that is out there and available now for a group of community-based organizations that are providing that sort of service. So so that is also signal is important. Talk a lot about staffing at the hospital, expansion of the healthcare workforce provider incentive program. Again, this is continuing some of the investments and around behavioral health workforce. Work to improve civil commitment services, especially those coming out of the state hospital that may be houseless. Work on substance use disorder facilities, adult intensive services, and jail diversion. Again, a long list of behavioral health priorities in the governor's budget. Next slide. Public health. So I talked a little bit about public health modernization. There's been a very robust community-based process with local public health and community-based organization and others to build a sort of post-pandemic, what it would take to have a fully modernized system. This really is a down payment to keep that work going. That will continue work with community-based organizations and local public health, while recognizing that the state public health has some core capacity needed in public health modernization, allows for those things to continue. And, you know, clearly a robust conversation with the legislature about where all of this will end up. We had a POP for regional resource hospitals for disaster response. This again is working closely with OHSU about how it will be funding, but recognize that this system is needed in the state. Was very helpful in the pandemic for coordinating resources and requests between hospitals. Their continued work and expansion of the universally offered home visiting program, assurance that OHA is learning lessons from the pandemic and PPE and medical supply management, working closely with our emergency management colleagues in implementing that work. And then continued work, some of this we had asked for in emergency boards around domestic well safety and the lower Umatilla Basin, making sure that we're in compliance with federal federal concerns that are coming down there. Recognition on the psilocybin services regulatory work that is just beginning, that there's enough resources to continue to do that work in the next biennium. Next slide. Questions. I talked very fast. I apologize, Kirsten and board, if there's anything that it is really an exciting budget to present. There's a lot of things in there, and a lot of expansion of things we've been doing, and some new work that we're excited about. So happy to answer questions.
Indeed. Any questions from board members? Jump in or raise your hand. John.
Well, thanks, Dave. You know, as I listened, I thought back to our definition of equity and the importance of the transfer of power and resources. And I really don't have a question, I have a comment. I mean, it's clear from your presentation that the state and this governor are making terrific efforts to transfer resources and power. 500 million for Healthier Oregon is incredible, and $1 billion in the waiver is incredible. But I would just remind my colleagues about a fundamental, inequitable, original sin in our system. Currently, commercially insured patients, when they get the same service as a Medicaid patient, on average their provider is paid twice as much as Medicaid and 80% more than Medicare. That's billions of dollars that are basically creating a decades-old inequitable system. It doesn't have to be that way. It doesn't have to be that way. You know, in a single payer system, reimbursements could be normalized. It could be done. And every patient would be paid at the same level. So this is terrific work under the circumstances we're in, but we shouldn't lose sight of our ability to change the circumstances we're in.
Well said. Thank you, John. Bill?
Just a quick follow-on comment and a small question. Dave, thanks very much for this very detailed and helpfully informative summary. I know there is a lot going on. Responding to John's comments that he just made, I think there is a major issue of differences in payment levels. I think it's part of a broader issue that we have a healthcare system that is designed poorly, and in some ways the kinds of things that can be done through a governor's budget and legislation, we're kind of swimming upstream against the way the system has been designed and built over more than half a century. But I think this is a valiant attempt to overcome some of those inequities that have resulted from that, and I very much endorse the governor's priorities. One smallish question about one item on here was, I think on the slide about investments in health coverage, 1115 waiver, there's an item for support of the healthcare market oversight program. And could you say just maybe 2 or 3 sentences more about that? Is there a sense that the volume is of potential transactions increasing, or has it turned out that that doing the analysis is more complex? What is the rationale behind the increased funding and increased positions for this program?
Yeah, thanks, Bill. Funny, I was just I've been in front of the legislature a couple times already, so I was about to say, you know, co-chair Isaacson, but sorry, I don't have to do that in this environment. So good question, Bill. So the so the healthcare market oversight program and the funds that the governor's budget is asking for, it's based on how the program was set up, and also the not great enough, like we just started on implementation of rules to where when someone submits for example, that, you know, an acquisition that or a merger entry, that they have to pay what the rules lay out for sort of a sliding scale of fees depending on what that is. It's a little unclear of whether that will be enough revenue to cover staff and other costs in that healthcare market oversight work. So what this assures is that there is enough general funds to support the staff to do the healthcare, to do the mergers and acquisition work and the cost growth target work, period. So it's not really new work, Bill, per se. It's more just because there's just not great clarity on whether the rules, the revenue gain from filing fees will cover all of that work. That is the intent. Well, kind of the intent, but it's just unclear of how many of those that will actually occur over the course of the next couple of years. And so this is just an assurance that there's enough money to keep paying and to do the work that is in front of that body. Hope that's helpful.
Great, that's very helpful, Dave. Appreciate that explanation. From my perspective, this is a very important program, and it's important to have it adequately staffed to ensure that the information gathering and analysis and assessment of proposed mergers and acquisitions is being done thoroughly and accurately and objectively. Appreciate your explanation for this, and I think it's an important program to have support for.
Great, thank you. I'm going to turn it over to Brenda for our last question.
Thanks, and I have two of them for you, Dave. The first is about your comment of headwinds. And I'm thinking with this specific budget and the amount of new resource that we're putting into the system, recognizing that state agencies can turn slowly sometimes, both in the ability to take this intention and put it into practice, and then also when those headwinds come on a bit stronger over time, conceivably less nimble to be able to accommodate and to react within the agency itself. So my question, that was a statement. The question is how are you thinking about the agency's ability to flexibly move under the constraints of a budget as the environment changes? So as we get new forecasts, or as we think about our spending patterns overall, how quickly can we move and navigate? And then I'll follow that with the second question.
Yeah, thanks, Brenda. It's a great question. Yeah, no, I think that there's sort of a set of challenges and unknowns as we look into the next couple of years. I think, we obviously have, forecasts and estimations of what the future caseload for Medicaid really will be as we get through redeterminations, right? Our caseload forecasters have looked at and done their best estimation of what sort of will happen as you get through that. But I think, Brenda, as you said, right, like as we go through the next couple of years, the overall economy may change. More people may actually lose jobs, that lessens income. That means that they would need to stay on Medicaid. Those have really big impacts for sort of overall budgetary needs. And, I think that the challenge for the health authority, and I would say for the Oregon Department of Human Services, is as the economy weakens, the need for additional resources and general fund for health authority and especially Medicaid increases. And so it exacerbates challenges for overall in the state budget. So, as far as I think flexibility to, to respond and, be able to you know, to take on those new challenges. You know, I think we, I'm pretty confident in our team to be able to both recognize to where, I mean, for example, this biennium, because both in CCOs and in fee for service, there was, you know, like the amount that was budgeted, there wasn't enough, there wasn't enough encounters to sort of, we actually gave money back this biennium because again, we didn't get there all the way. It may be a little bit opposite as we look into the future. I think we have the structures and processes to recognize where those shifts happen. And, you know, depending on sort of what fully headwinds we encounter, you know, positions and what happens to overall workforce for the state. Yeah, I think there's some challenges that I think the state will have to encounter if there is a much more significant downturn. Some of our programs are very much tied to tax revenue directly. Measure 110 is a great example of that, tied to sort of the marijuana revenue. If that drops, the amount of available resources for Measure 110 drops. So there are some direct sort of correlations and some indirect depending on the state. I hope that was helpful in that. I'm looking forward to your follow-up. This is great.
Yeah, it's my follow-up was actually on a different topic, and I know that's kind of a really hard question to ask about how quickly or how long does it take to react to significant changes in the market. So I apologize for the complexity of the question. It's kind of a hard answer to give. And thank you for what you shared. My second question is specific to the workforce shortages and where I sit as the liaison to the Healthcare Workforce Committee. But of course, I'm obsessed with the idea around how we're investing in the workforce supports in healthcare across Oregon. And so I know we just earlier in today's agenda heard about investments in the healthcare provider incentive program as an example, and many, many more applicants who could benefit from those incentives than we currently are resourcing. So a little bit hidden question, I suppose, is how do we think about expanding programs like that while we're in the middle of a governor's or the approval process for the budget itself, again, as there are new initiatives or additional demands on resources that are not yet fully expressed?
Yeah, thanks, Brenda. No, I mean, so many thoughts on this one because you are spot on. I think you know, both with addition, I mean, I'll speak probably more on behavioral health, but we'll for sure on healthcare generally as well. You know, I think we all should be doing everything we can to figure out new innovative ways with state support, private support, other ways to encourage and expand people to go into behavioral health and healthcare generally. I am definitely worried, as you know, we're bringing a lot of new additional bed capacity into the state for behavioral health, for example. Will there be enough people to be able to staff those beds? And I think that's going to be a significant challenge. And I could, you know, sort of do a couple of specific things that we have been supporting sort of throughout the pandemic, that honestly, if the market and people were available, we wouldn't have to keep doing those. So we have been, for example, providing upwards of 150 staff throughout since August of 2021 to today in behavioral health residential facilities around the state. That has continued. I will say that we have tried to work with facilities of like, what have you been doing? What have those particular facilities been doing to incent and work, and lots of new resources, from rate increases in behavioral health to one-time grants to help do those things. And still we hear back so many challenges remain. They're like, I mean, very specific feedback. You know, we doubled our salaries. And we put out a much broader look for specific providers, and we received 0 applicants. That's a really challenging place to be, of all of the variety of places. So I think you are hitting on such what will be is felt acutely right now, and will continue to be felt acutely in the whole healthcare field. And I think I think there are some investments in the governor's budget that hopefully will keep pushing in that direction. And the benefits of a lot of these incentives from helping with student loans or tuition assistance won't see benefits for into the workforce for a couple of years, but you've got to start somewhere to get people trained to do that work.
Just a really quick comment on that too. The other piece that I'm hearing is on the background checks. I mean, people are trying to recruit from out of state and even some foreign nationals to fill those positions, and it's months backed up. And by the time they can even get to the point where they're receiving that information back and they can hire, those people are gone. And that's an issue with sort of the operation of background checks at the state level. So that really needs to be addressed. And it's been an issue. I mean, gosh, I've started hearing about this all the time, probably more than 5 years ago, and it still has yet to be dealt with.
Yeah, thanks.
Thank you.
Thanks for that, Jessica.
Yeah, thank you all. Thank you, Dave. Appreciate the overview of this budget and reflecting on its priority areas. So speaking of priority areas, potentially we'll I don't know if we're going to get to you, Mark, but we're going to try to come back to that. But next up is Dave Inbody, discuss coordinated care organization CCO 2025 contract procurement. So Dave is OHA CCO operations director, and he's back with us again, which we so appreciate, to discuss CCO 2025 contract procurement. Slides for that are included as 7.0 CCO contract procurement in the agenda. And Dave, thanks so much for joining us again today. Kick it off when you're ready.
Great, thank you. I appreciate the invite. And as Kirsten mentioned, I'm Dave Inbody. I'm the CCO Operations Director. And I think this is one of those questions where, because there's so much going on, it's really important to identify exactly what we're trying to focus on at this point. Sometimes it's very easy to get, I guess, off track because there are so many aspects to this that are yet to be decided or beyond our control or consideration. But I think the place where we really are looking for the Oregon Health Policy Board's insight and perspective is some of those considerations as OHA kind of develops and navigates this process. And we've had a couple of discussions thus far, last couple of meetings. And last week we had a meeting with a subset of the Oregon Health Policy Board to begin to talk through some of those questions. And these are the questions that are kind of agnostic to all the other considerations that have been shared, many of which have been shared here today. So those things that we basically are going to want to be able to answer or consider regardless of what may change in terms of the procurement process itself. And some of those things, when James Schroeder had mentioned many of the things that were going on, and Dave Baden's reiterated that. And then how does this fit in with that process? And I think part of what is helpful is to understand kind of how some of these large projects fit into the procurement process. For example, the work around the waiver, much of that work is going into effect either this year or the beginning of next year. And when that happens, then we make adjustments on an annual basis to what's included in the CCO's contract. And basically do an annual restatement of that contract. And that process continues regardless of the timing in terms of the procurement process. And so that's something to take into account, is those federal and state changes or adjustments that happen outside of the procurement process. Those are then incorporated into the CCO contract. The other is, when you think about things such as the redetermination process, the potential for the implication to that work on those who are covered under Medicaid is significant. We start that process in the spring, and by the summer of next year, there's going to be a significant impact to who is actually covered under the contract that we're talking about that has implications. And then the other part of it, the basic health plan basic health program. Basically, the idea being that those that are kind of no longer qualified for the Medicaid contract could potentially roll into this basic health program, with the idea that then it would be opened up to anyone within the qualifying incomes on January 1st of 2025, which aligns with this contract potentially. And so the question becomes, how does that alignment, what's the significance of that alignment, and what does that look like in terms of procurement? Because the reality is that we'll potentially have to go through a procurement process for the basic health program. And what does that look like in relation to the CCO contract or CCO Medicaid contract? Currently, when we go through that CCO Medicaid contract, a residual aspect of that is when the CCOs sign on to that Medicaid contract, they're also basically agreeing to what we now refer to as the non-Medicaid contract. And that's those individuals who don't necessarily qualify for Medicaid, but are still covered under OHP. And we had just heard through the budget discussion that one of the considerations there, a large consideration, was the expansion of the Healthier Oregon program. That's an example of someone who would be covered under that non-Medicaid contract. Now there again, we don't do a procurement process for it, but it's incorporated into the Medicaid CCO contract. And so considerations similar to that would be what would we do with the basic health program. Along those lines, the other was also the implications of the legislative activities. Now we'd heard from government relations the many different places that would potentially be altered because of the legislative process and the legislative considerations that are under review now, including two that are directly impactful, potentially could directly impact the procurement process. So those are all things that are kind of outside of the points of discussion that we were looking to have with the Oregon Health Policy Board. Really where we were trying to focus is more on a couple of broad questions. What are the basic expectations we have for CCOs, and the vision for the program? Is the CCO model where it needs to be now? What's working, what's not working, and where would we want to address those critical places where there are gaps? And that's in preparation for this next procurement process. Again, those are those deeper discussions that we want to have and start to think about with enough time before we get to procurement. And the other part of that is also the consideration of some more specific questions about the procurement process. And this is kind of where we wanted to have a bit of that discussion today. So some of the things that came up in the subgroup that we had with a couple of people from the Oregon Health Policy Board was some general themes and general themes that I think we've also heard today, but I think when we're talking about relating it to the procurement process, what that looks like is important and taking that into account. One of which was the community input to drive decisions. How do we incorporate the community into that process in a way that maybe we haven't done in the past? We've always done work out in the community, whether it be listening sessions or whether it be communication with members, that type of thing. And one of the points of discussion is this ongoing discussion of redistribution of power, is how do we actually develop a procurement process that not only takes into account the interests of the members and the communities, but have them be a part of that process in developing that next procurement and before we release it. So it isn't something that we're listening to those out in the community and then coming back and developing something on our own. It's how do we work at an ongoing and collaborative basis over the course of time to make that happen. Another consideration that was brought up in the discussion was accountability. How do we look at what we're currently doing in terms of accountability? Is it working? Where is it working? Are there things we need to do differently? And I think there's kind of a push and pull in terms of what makes sense for accountability. On the one hand, we want to provide enough accountability so we know that the things that are actually required in the contract are being done by the CCOs. By the same token, we don't want to provide too much of a burden in terms of the administrative responsibilities to ensure that it happens, in having the very burdensome reporting requirements, for example. And oftentimes those requirements that are then passed on to the providers to ensure that the CCOs have the information to provide to OHA. So trying to find a balance there, and to what extent can we identify where that's worked well and where that hasn't worked well. Another consideration was the implications of the public health emergency. Obviously, the way that we operate has changed, and of those things, what would be continuing on in a new contract and what might be going away, and taking that into account in the development of the next procurement process. And then variances between large and small markets and large and small CCOs. We've seen significant differences in how they perform based on the markets that they're operating in and the size of the CCO. And as was just mentioned, consideration of network adequacy based on regional impacts, how that impacts certain programs and the ability of CCOs to carry out certain programs. Also was interested in learning more about what it is that in the programs that are working well and those that are underperforming, first of all, based on the lack of workforce support for those programs versus the places where CCOs aren't performing what they've agreed to in contract, and trying to clarify those distinctions, all a part of the accountability considerations. The other was also just talking about the process and the scope, and some of this has been discussed here as well, but the idea of how best to include community in this process, and also the idea of whether the procurement process makes sense to delay. I think there was a general sense among the OHPB members that a delay makes sense, but also an interest in learning more about the implications of delaying or not delaying and what that looks like. So for the meeting today, I think the best thing is to focus on some of those more specific questions and try and get a sense. And I think it's as important, not just in answering the questions, but in understanding the significance of the questions in laying out for the next procurement process. And again, these are things that are going to be important regardless. The first, obviously, is the scheduling consideration, weighing the positives and negatives related to staying on track, whether a 2025 start makes sense or a delay. And again, one consideration here is the legal consideration of, in state statute right now, the contract is dictated at 5 years. So in order to change that, it'll require legislative action. And that's where the implications of those bills that were highlighted earlier are going to be important. If those changes do occur, then we do change the time frame for the contract. And the other is the idea of what if we don't do another procurement process, what that means in terms of the ability to make changes to the contract. And what's important here is that currently we have the ability to amend the contract, and we typically do, as I mentioned, a restatement on an annual basis. And that restatement basically allows us to make adjustments, and those adjustments are oftentimes changes in federal or state law, and periodically there may be changes that were made in terms of carrying out what was in the existing contract, modifications to that contract. What it doesn't give us the ability to do necessarily is make significant changes in how we approach the procurement process. So it has to stay within ultimately within the scope of that original procurement. So in order to make significant and marked change to how we approach this, it would require a new procurement process. The second question is specifically about the idea of a competitive versus a collaborative procurement process. And what that means is that we have the ability to be completely open in terms of who qualifies for or can actually be eligible to apply to be a CCO. And that, if you think about it, you open the door to that procurement, and then anyone who feels like they want to apply can. And that's the most extreme on one end. And then the most limited version on the other end is where we limit that procurement to the existing CCOs. So only those who are CCOs today would be able to apply. And so that's the two extremes, but an important question about where we want to be along that continuum. There are, on the one hand, the open perspective gives us the opportunity to say that it is open to anyone who is interested to apply. What it does, one of the limiting factors is that we've had several CCOs operating for over a decade. And so we'd be starting over if we were to change. And then the reverse is true on the other end. The limiting approach does give us the ability to work with partners that have already been doing this work for quite some time. and allows for things that they've started to continue, but it does limit the ability to bring in new participants in the process. So that's another consideration that's critical to this process. And then the last is as it relates to the choice question in terms of CCOs. Right now, there's some areas of the state where an individual has a choice between multiple CCOs, and then other parts of the state where there's only one CCO that represents their service area. And so, and the way that generally breaks out is most of the places where there is choices, the more urban areas, and the places where there's limited to one CCO tend to be the more rural areas. But in terms of population, it's about even. So it's almost a 50-50 split between those members who have choice and those who don't. But the question is, moving forward to the next procurement process, to what extent do we want to promote one or the other, or to leave that open to allow for some flexibility? And some of that also goes to the question of identifying service areas for consideration. To what extent would a service area be a development, as it has been in the past, of a CCO making the application, or would we want to define more specifically what areas would be covered within certain regions, for example, that would then a CCO might be able to apply for that particular region. But these are the broad questions that we're hoping to get some thoughts in terms of where the Oregon Health Policy Board has in terms of these questions as we move forward, because I think these are some of those, again, critical questions that will allow us to set the foundation for the next procurement process.
Thank you, Dave. Are there any board members who have, oh, actually, could we leave those discussion questions up, please? It'd be great if board members have any clarifying questions or reactions. I think it is valuable for us to reflect and convey. So that's Dave is driving a lot of work here, and it's very important. And I think we want to make sure that kind of the board moves forward with OHA, with the governor. And so as much as we have considerations, now is a good time to share thoughts, especially on these discussion questions. Brenda, go ahead.
Thank you. Just recognizing we're coming close to our time together, and I apologize, Dave. I know this is such an important conversation, and one that I know that along with my colleagues and fellow board members, we want to give it the right amount of attention that it absolutely deserves. So hopefully we'll continue this conversation. I wonder around, so I don't know that I have a clarifying question necessarily. I feel heard and understood, and I really appreciate the themes and the way that you've digested and reframed the information for us, even in the flow of the conversation that you've presented for us here today. I love the idea of understanding more about the implications of the delay. So I suspect right now my comments I'll limit to question number 1, and wonder when you might be able to have that for our consideration. You know, I can easily say reasons why it makes sense to delay, you know, and under what set of circumstances might that be a bad idea.
Yeah, I appreciate that. And I think that is a critical question, is making sure that we have enough information about, you know, what it means to delay and what it means to move forward. And we're in the process of putting that together now. I think that is reasonable, that's something that we can share, whether it be in a future meeting or making sure that it's directed back to the policy board so that you have that information. Because I think that's one of the critical questions, is what are the implications depending on which way it goes, especially as it's being discussed at the legislative level as well. You know, part of this process is we'd like to be able to provide enough information, whether it be to the governor's office, leadership of OHA as well, so that as we move forward, we kind of have that laid out in terms of what we're choosing to do and the implications of that, or what we're not choosing to do.
Thank you, Dave. I'd especially like to see if any board members who are not in the small group conversation have any reflections to share, right direction, wrong direction?
Hey, Kristen, this is Kara Talk. Jessica Gomez had to jump off, but she said that she would like to continue this discussion at the next meeting.
Great. Yeah, I do. I think it is very unfortunate that we are running out of time for this pretty important topic. So Dave, we keep asking you back. All right, we'll figure out how to do that efficiently and respectfully. But I do appreciate your time and reflection on this, organizing these questions. And I have to concur with Brenda's comments. I too am also like, yeah, it seems like it could be wise to delay, but what is the cost? And you started to go into that. I will add that the 10-year kind of gives me some pause. In case that is helpful. Okay, well then if there aren't any other burning opinions that people want to give to Dave right now.
John has his hand up.
Oh, thank you. John, go ahead.
Kirsten, could we submit some written thoughts on those questions to Dave?
I think that would be great. OHA staff should speak up if we wouldn't, but that sounds efficient.
Yeah, I think that would be greatly appreciated.
Okay. Mark Overbeck, my apologies. We will have to figure out how we get their update on administrative costs. Thank you so much. Okay, well, with that, then we will wrap up. And thank you all for being with us today. I do want to highlight that on Tuesday in a couple weeks, on February 21st, the Health Policy Board is hosting an educational webinar on the Community Information Exchange, CIE, and House Bill 4150 legislative report. So additional details about that educational webinar, apologies if you can hear my dog, including meeting links, are posted on the Health Policy Board website, which Tara just very helpfully put in the chat. So our next full meeting of the Oregon Health Policy Board will be Tuesday, March 7th at 8:30 a.m. until noon. And I look forward to seeing you all on Tuesday before then, hopefully, and then at our next official business meeting. Great. Thank you so much, everyone. Hope you have a wonderful week.